morning, everyone. Welcome to day 2 of the August 2023 quarterly board meeting of the Medical Board of California. Just a few housekeeping items before we get going. I'd like to ask everybody to please turn their mobile devices and any of their computers to silent. You may notice that board members are accessing their laptops, phones, or other devices during the meeting. They are using these devices to access board meeting materials that have been provided in electronic format. If you're a member of the media and require assistance or additional information, please see Emily Ross, who's raising her hand here in the second row. This is an official business meeting of the Medical Board of California, and as such, disruptions allows the board to remove people who willfully interrupt a meeting and to clear the room or the virtual space if order cannot be restored by removing or muting the disruptive people. It is the board's intent to ask for public comments prior to the board taking action on any agenda item. And if for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand or come forward and you will be recognized. On agenda item 11, which is really the substantive agenda item that we have on our agenda today, we are going to be grouping public comment. So if you look at the agenda, there's a group of 3 speakers, national state perspectives, and there's a group of 2 additional speakers, local perspectives. We're going to be taking public comment after each of those groupings. So there'll be 2 opportunities for you all to provide us additional information in your comments. This meeting is also being webcast and is available via teleconference. Individuals who are listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public that are participating via teleconference, please do wait until the moderator has introduced you before you make your comments. Like yesterday, to request to make a comment during the public comment period, please press star 1. You will then hear a tone that indicates you're in the queue for public comment. If you change your mind and do not wish to make a comment, please press star 2. Assistance will be available for you throughout the teleconference meeting, and to request a specialist, please dial star 0. After the allotted time for speaking has lapsed, the speaker will be placed on mute. And again, like yesterday and our previous meetings, only 1 public comment per agenda item will be allowed per individual. I would like to remind all speakers to please stay on topic. Please keep your comments to 3 minutes or less. Please be aware that this time period could be reduced depending on the number of people who wish to speak so that more people may be heard. Today's meeting will be run according to the Open Meeting Act as required by law. We do plan to end today by 3 p.m. I would now like to call this meeting of the Medical Board of California to order at 9:08 a.m. And Ms. Lopez, if you would please call the roll.
Dr. Balat? Here. Mr. Brooks? Here. Dr. Hawkins?
Here.
Dr. Hauser?
Here.
Mr. Watkins? Dr. Mahmood? Dr. Sai?
Here.
Dr. Thorpe?
Here.
Madam President Lawson?
Here. Thank you. A quorum is present. I'm not going to remind the members that we'll be taking a roll call vote because we don't have any action items on our agenda today. Okay, we are going to move on to agenda item 11, discussion on maternal health outcomes in California. I want to again thank the Bakersfield and the greater Kern County communities for having us here in your community this week. We're grateful for the opportunity to be here. We're grateful for the opportunity to interact with and speak with so many of you in person. So many of you have been attending our meetings for many years, and we haven't had the opportunity to meet you in person because we haven't had the opportunity to have a meeting in your community. So we are grateful for the opportunity to be here, and we're particularly grateful for this slate of speakers on this incredibly important topic. Our goal for this meeting is to highlight the topic of maternal health outcomes, the disparities that exist, and the efforts that are being undertaken at the national, state, and local levels to improve maternal health outcomes. We look forward to hearing from experts in this arena and from all of you in the public who took the time to be with us here in person or on the phone to provide their important perspectives. It's my pleasure to introduce our speakers who will be presenting on national and state perspectives first. My introductions today will be brief, but their bios are included in the materials. First, we're so happy to have our friend and former medical board member Denise Pines with us today. Ms. Pines is the immediate past president of the Medical Board of California. She preceded me, and she currently serves on the boards of the Osteopathic Medical Board of California, the Federation of State Medical Boards, and the Martin Luther King Jr. Medical Center in South Los Angeles. Among her many roles, Ms. Pines is an executive producer and co-writer for Birthing Justice, and she will be sharing a clip from that documentary with us this morning. I would also like to welcome Dr. Kern Ramstrom. Dr. Ramstrom is a preventative medicine, public health, and family medicine physician and is chief of the Maternal Infant Health Branch with the Maternal, Child, and Adolescent Health Division at the California Department of Public Health. Dr. Ramstrom has worked in the field of public health for more than 23 years, including 12 years with CDPH. And additionally, I'm pleased to introduce Dr. Kimberly Gregory. Dr. Gregory is board certified in obstetrics and gynecology and maternal fetal medicine, and she maintains an active clinical practice in high-risk obstetrics. Among her many roles, she is the fellowship and division director for the Division of Maternal Fetal Medicine and is a professor in the OBGYN department at Cedars-Sinai with a joint appointment at the David Geffen School of Medicine at UCLA. She is currently serving as chair of the American College of Obstetrics and Gynecologists Women's Preventive Services Initiative Advisory Board, and the Southern California Maternal Mortality Review Committee. We are so grateful to all of you for participating in this important meeting this morning, and we will begin with Ms. Pines. Welcome, Denise.
So, do we have the clip? Okay, great. So I was led to produce this film when I heard the statistic about Black women, and I thought it was actually really a joke. I thought it was inaccurate. And when I found out across the country that these numbers were not inaccurate, and in some places they were triple the general number, I felt like I had to do something. And as a filmmaker, I felt like I had to tell this story. So I want to show a 3-minute clip of Birthing Justice. Who has a clip? Oh, I don't have a clip. Oh, I sent you guys a clip. Carrie? Okay. I might. Yes. Yeah. There's if you go to Birthing Justice on YouTube, there should be a clip called Trailer. So for the sake of time, why don't I start my presentation? Okay. So first I want to just thank the board for really bringing this really crucial and critical conversation to a broader population, a population that represents physicians and others that are in the healthcare industry. It's heartening to also see that there's so many influential leaders that are here today spearheading a number of initiatives up and down our state, and I can't wait to hear from them today. You know, the state of Black maternal health in the United States has reached a critical juncture, a crisis that has persisted for numerous years. Our maternal health rates are even more alarming than they were 3 decades ago. I mean, this sobering reality becomes all the more distressing when it's juxtaposed with the remarkable advances that we see in health technology today. This urgency underscores the need for immediate and comprehensive action so we can bring more what I call genuine happiness to Black families. Okay. Am I supposed to point this somewhere? There we go. Maternal mortality is the death of a woman during pregnancy, at delivery, or soon after delivery. Maternal mortality can happen even as late as a year to 18 months at the end of the pregnancy. Even though women of all backgrounds suffer from maternal mortality, it is considered a health disparity because disproportionately it affects Black women as it relates to complications during pregnancy or childbirth. So before I go into detail about maternal mortality as a health disparity, let me explain what a health disparity is. Health disparities are noticeable and preventable differences in the incidence, prevalence, mortality, and burden of a disease and adverse health outcomes that exist among specific populations when compared in contrast to a larger group. An example of this is what we're talking about today, maternal mortality in Black women. And even though all races and ethnicities experience maternal mortality, Black women have higher rates of maternal death, especially when it's compared to white women. There we go. The U.S. is actually failing. We are the only industrialized nation in the world where maternal mortality is rising. 80%, though, of those deaths are preventable. And California is considered to be a leader. It has better outcomes. But if it were really to be graded, it would get a C-. Okay. Put yourself in the shoes of Black women. Imagine that you are more likely than any other woman to experience maternal mortality solely because of your race. Well, that all over the country, that's what Black women are experiencing and feeling. They're feeling stress and anxiety. And the worst states for maternal health are mainly in the South. And what they have in common is limited access to health care. The Affordable Care Act required that all 50 states make more people eligible for Medicaid, yet these states still haven't expanded the program. Many of them are in the South. They have fewer places or options for getting care, and they have more racial segregation and income inequality. What the best states in maternal care look like are California, Massachusetts, Minnesota, New Hampshire, Oregon, Vermont, and Washington State. And they have in common what the opposite of what the worst states. They have expanded healthcare access insurance. They have more options for full spectrum birthing care like midwife assisted births or doulas, which are associated with fewer interventions and better maternal and child outcomes. They have enhanced prenatal services like nutrition and health education through the Affordable Care Act in California, and they have paid leave and sick leave. Out of every 100,000 births, 70 Black women tragically lose their lives, in stark contrast to the overall 33 deaths among all women in the United States. This concerning disparity is further exacerbated and worsening in this trend, as we can see, over from 2019 to 2021. So we're not getting better. In California, and I know my colleagues will be talking about this in a few minutes, the data here shows that we are doing better, definitely as of 2006. But we know that the data quality issues are inherent in death certificate data, such as missing or inaccurate information about pregnancy status and timing of death and cause of death, can result in underestimations or overestimations of what the true burden of pregnancy-related mortality really is. Again, we are specifically talking about Black women today because this chart, which shows pregnancy-related mortality ratios by race and ethnicity in California over 3-year periods, shows that Black women are dying 3 to 4 times the rate of Hispanic, Asian, and white birthing women. So what are the main causes of maternal mortality? They include, but are not limited to, blood clots, preeclampsia, which is associated with high blood pressure, and the increase in protein in the urine, which typically begins around 20 weeks after pregnancy, infections, cardiovascular conditions, hemorrhaging. Black women experience something called weathering, and what that means is their body age faster than white women due to the exposure of chronic stress linked to socioeconomic disadvantages and discrimination over the course of their life, beginning at birth. This is making pregnancy riskier even for younger women. So I'm sure you're wondering, why do Black women experience such extreme outcomes even when compared to other women of color? But research shows that implicit bias can cause doctors to spend less time with Black patients, leading them to receiving less effective care, underestimating pain, and dismissing their complaints. And it doesn't matter, honestly, if you're Beyonce or Serena Williams, who while pregnant complained about trouble breathing. She had to continuously pressure her providers to perform tests, but they still wanted to chalk it up to medication. And finally, after persistence and really threats from her husband, they did a CT scan and found she had blood clots, and they treated her, indicating that no money, education level, or fame can buy a Black woman respect in healthcare. Just think of this. Black mothers who are college educated fare worse than women of all races who never finished high school. Or a Black woman in the wealthiest neighborhoods do worse than white, Hispanic, and Asian mothers in the poorest neighborhoods. So we discussed attitudes about health providers, but other disparities persist, like socioeconomic status, which means the combined total measure of a person's work experience, resources, and social position in relation to others. Implicit racial bias, the example I mentioned of Serena Williams, a Black woman who was treated unfairly in a hospital even when giving birth, which can eventually lead to the risk of maternal mortality. And finally, underlining chronic conditions, which are brought on by health disparities, can increase a woman's likelihood of maternal mortality by making it much harder for a woman to maintain a healthy pregnancy. Other social determinants that impact birthing health outcomes include the ability to get nutritious food, transportation to go to doctor's appointments, obesity from food deserts, safe neighborhoods, and rising housing costs impacting stability. The cycle of implicit racial bias starts with inaccurate beliefs about the biological differences between Black and white individuals. Then this leads to physicians giving people such as Black women inappropriate treatment because this is, because of this, Black women then begin to avoid hospitals and other healthcare facilities since they are not receiving proper treatment that they deserve. And although this ends up creating higher maternal mortality rate in Black women because they're not getting the healthcare by not going and visiting their doctors. Here are some of the factors that prevent Black women from receiving care, poverty being number one because they live in an environment that does not have resources for pregnant women. Distance, when hospitals are 50 to 100 miles away. Lack of information, when women are not informed about different resources or benefits or educated on the ways their body are drastically going to change during pregnancy. Cultural practice, healthcare providers that lack understanding of the community that they're serving might influence a woman's pregnancy outcomes. Inadequate services can make Black women feel that they cannot be assisted in the environment that they are in. Chronic conditions like obesity, heart disease, substance abuse, and hypertension can also cause maternal mortality. And these are conditions that typically are a result of socioeconomic disparities. Okay. Black Americans have a complicated history with America due to the past and present experience of racism and oppression, especially when it comes to healthcare. The Tuskegee experiment, the Harrieta Lack cancer cells, and J. Marion Sims, known as the father of gynecology, who perfected surgical procedures by repeatedly operating without anesthesia on enslaved women in the 1840s, have fostered cultural mistrust towards the U.S. healthcare system. So many people face a conundrum in the U.S. healthcare system because it was never geared to treat Black, brown, indigenous people, and even women. And so when we're talking about healthcare in the first interaction with Black people, we're talking about the enslavement of an African woman and then them being tested in order to advance medical science. And then we have the Reconstruction era where you have Black men who can vote and then they can't vote, but women still can't vote. And then you have Jim Crow, and then you have the Civil Rights era, which led to desegregation. But along the way of these changes, we never taught anybody to deconstruct from patriarchy or superiority constructs. So how does this show up in healthcare? When for hundreds of years we've lived in a space where people have been told you are less than. But now these healthcare providers need to take care of you, but they've never been talked to about what it means to remove these biases, those years of racial constructs or traditions, because it is a tradition. It's a tradition of racism that has been in place, and now I have to care for a body that you were told to disdain. And so we need to restructure our medical education. We need to talk about the ways in which we're caring for communities. We need to come to terms with the reality of what does it mean for us to remove ourselves from transactional relationships to interpersonal relationships in healthcare to achieve positive health outcomes. And what does it mean to end structural racism in institutional policies like practices of Jim Crow and redlining and mass incarceration that are historically based features of an overtly oppressive U.S. society that have endured and adapted over time, and yet these continue to shape contemporary access to healthcare. And how do we find ways of promoting resources and opportunities necessary for optimal Black maternal and infant health outcomes? We can change these outcomes with a willingness to address the racial and social inequities. But it takes all of us. It takes healthcare providers, policymakers, philanthropy, hospital corporations, and families. It's possible, but it's not going to happen without intention to work towards better outcomes. But the good news is that we can. There's ways that we can expand and maintain health resources and coverage for Black women. We could recognize the bias and stereotypes about Black women and try to end it by educating the system at all levels of her health journey. We can formalize existing relationships between lower resource hospitals that transfer pregnant women who require higher levels of maternal care, and we can address the social and economic factors through policies such as increasing Medicaid and providing stable housing and transportation access, and eliminating food insecurity and racial and economic inequality. All of these could positively impact maternal health. All parents deserve a beautiful health birth experience that aligns with their values and their needs. But this is not the case for far too many women in the US, especially for Black women. We have to do something different, address this disparity, because it is literally killing women, and as we've seen recently in the data, it's actually increased, and our most recent data is in 2021. We need to move from, as I said earlier, transactional relationships to interpersonal relationships in healthcare to achieve positive health outcomes. And to get there, we need to listen to, act on the wisdom and the solutions of the women that are most impacted by this crisis. The presentations that follow, I know, are going to share some of the best practices and changes and outcomes in our state, and I'm really excited about listening to that later today. So I want to thank everyone for the opportunity, and if anybody is interested in more resources, you can go to birthingjustice.com, and I want to thank partners like RH Impact for the research and policy work that they have been doing that is improving outcomes all across the country. And I'm happy to answer any questions.
Thank you, Denise. Do we want to play the clip now? Do we have that ready to go?
Yes.
Okay, why don't we go ahead with that?
I don't know if you've ever witnessed a birth, but I remember the first delivery room I was ever in as a student nurse. It was a joyful, exciting, incredible experience, and that's something that should be available to every family.
Hi, how are you? Hi, I'm Ebony. I came back just for you so you could check your baby. I went back on the table. So is this a boy or girl?
Don't know.
Oh, it's a surprise?
Yeah.
Oh, I
Until
love
next
that.
week.
Oh, until next week? Oh, okay. You guys are really patient.
Yeah.
I wanted to know, like, immediately. Oh, come on, sir. You about to do this work. When I think about not only generational trauma, but also just the regular habit of trauma, I feel like in this world, in this society right now, I feel like everybody's coming into this life transition with baggage. So come put your hand right here. So you put your hand where my fingers are. Right, push it in. You feel that little hard thing against your fingers? That's the head. One thing we see in birth is that folks don't always disclose, but unfortunately in that state, in that, vulnerability, things are exposed. And so from our standpoint, we basically treat everybody like they've had some kind of trauma without even asking. It's just way too common. There you go. That's perfect.
The biggest misconception is there's something that we are doing. There is something inherently wrong with our body, our makeup, our genes.
I'm just joking.
There's something that we're eating. There's some ways that we are behaving, that somehow these bad habits have put us in a situation for poor maternal health outcomes. And there's nothing that we are doing that is so different than anyone else in this country.
So you're good to go. Baby sounds great.
But for some reason, it's always easier to point to individual level behavioral factors as a source of the issue. And we pour so much money into trying to, change what people eat, how much they exercise, what they do. And you can see that poor white women with less than an 8th grade education have better outcomes than black women with college degrees.
It's not race. It's racism. That's the issue.
Can we just bring the lights back up in the room too? Thank you. And thanks so much, Denise, for your presentation and for being with us here in Kern County this morning. Are there questions for Denise before we hear from the other two presenters?
Well, I just want to thank Denise. I'm sitting here and I feel like I'm in a time warp because I've been working in South Africa with HIV, and a lot of this that you are pointing out is the same thing. Mm-hmm. That was a black government that instituted that. And my point here today was we become desensitized to black people.
Yes.
And when you become desensitized, this thing impacted me because it just takes me home. When you become desensitized to black trauma, specifically, and trauma overall, it's so easy. Your mind switches off and you don't look at simple details that end up being mistakes. And because you're desensitized to the other people, they don't look like me, then it's easy to justify, oh, well, that happens in that community.
Yes.
And you have a justification in it. I just want to say, wow, this was impactful for me personally.
Thank you.
Thank you so much.
Thank you. I appreciate that.
Wow.
Dr. Hawkins?
Yeah, great to see you again. Thanks again, Denise.
You too.
So I'll have more questions at the end of the other two presentations, but it's a reminder that it takes a village to solve complicated problems.
Yes.
But we can do it.
We can. It is a complex problem. This is not simple. It may have been simple 40 years ago, when it was maybe just simply access to health care. But now it's much more complicated. I mean, the cost of, delivery, 40% of women who deliver in hospitals are delivering under Medicaid, and Medicaid fractionally covers those deliveries. So many hospitals are getting rid of their maternal wards because they can't afford to keep the maternal ward there, or they can't afford the sort of supplemental and complementary services like midwives to work along with OBs. So it's definitely a major problem just up and down the state. I mean, it's not that, white women and other women are not dying, but they're not at the rate. I mean, so we need to correct for all women, but Black women, as we can see these numbers, I mean, I can't make the numbers up. And in some states, they're 20 times more likely to die. In the state of New York, depending on what part of that state, they're 20 times more likely to die.
Other question, Dr. Thorpe, and then we'll go to Dr. Blunt.
Denise, nice to see you again. Thank
You
you so
too.
much for that presentation.
Thank
It
you.
is, and I just want to echo what Mr. Watkins said. As a father and as a physician, you don't always realize the implicit bias. And I obviously, as a father, I'm touched by the tenderness of these scenes, and it is very touching. But also, something Mr. Watkins just said really resonated with me, is that you harden yourself in a way. Mm-hmm. And I recognized, as he said that, as in my residency training, you had to stiffen yourself, you had to harden yourself mm-hmm. to pain and to suffering, because if you didn't, it would just crush you. Mm-hmm. It was just overwhelming. And so you develop this pattern of kind of holding yourself away, making yourself a little bit more aloof, especially when you're doing, maybe not in specialty so much, but in primary care, mm-hmm. it's just always there. Mm-hmm. And so unless you pull back a little bit, you become emotionally crushed. Mm-hmm. And I think that's something I never saw before today. Mm. So I appreciate your presentation.
Thank you for sharing that. I think having more honest discussions about the position from which a physician is engaging with a patient also helps for us to figure out, what are ways that we can help the physician, so that the physician becomes more receptive to their patient and just doesn't go, that's another person. That person reminds me of that last person I just saw saying the same thing, but this person may be saying something different that I really need to hear. So I think I really appreciate your comment. Thank you for sharing.
Dr. Blunt.
Yeah, thank you so much, Denise. Such brilliant work and so masterfully produced and so important in a time when this has been going on. I listened to this 30 years ago, and instead of getting better, it's actually getting worse. And I think the discussion of it doesn't matter about the woman's socioeconomic status, her wealth, all the rest of it does. But I think something you also said on the Medicaid, for many of us, we see that our women are being shuffled around with having very little access, with doctors that a few take the Medicaid, right? Mm-hmm. Because it's significantly different. And these disparities have impact. And as Dr. Thorpe said, and what a beautiful thing you mentioned, it is true. We do, in a sense, desensitize ourselves, because at the end of the day, if you take it all in, you take it all on, it's very, very challenging. And so having those crucial conversations is important. So my question to you is if you had one message for policymakers, what might that be, Denise?
I think addressing the social determinants of health, initially what I think they can do, like immediately, is increase Medicaid. If I was a policymaker and I was listening to this conversation and said, what can I do today? It would be to increase Medicaid, right? If a birth costs $6,000 and Medicaid is paying $2,500, that is not, that hospital cannot possibly deliver good care. They just can't. The numbers just don't add up. So I think that if we could increase Medicaid to support those 40% of the population that's giving birth, to pay for that birth correctly, at the appropriate amount, and also provide for prenatal care, I think that will make one of the largest difference in maternal mortality with all women, including Black women.
Any other comments or questions before we invite the next speakers to join us? Okay, I would like to invite Dr. Ramstrom and Dr. Gregory to join us. I believe they're joining us online, and they'll be presenting online.
Dr. Ramstrom, Dr. Gregory, you can go ahead and come off of mute now.
Great, thank you. Wonderful, thank you so much. And a note of appreciation to Ms. Pines for setting up the conversation today. This is such an important topic, and we're really pleased to be able to speak to you about it today. Again, I'm Karen Ramstrom. I'm with the California Department of Public Health, and I work with the MCH, Maternal Child Adolescent Health Division. Next slide.
So if you just give us a minute, we're not seeing your slides yet.
Okay, sure. Just let me know when to proceed.
Thank you. And if we, for members, if we could just make sure to speak into our microphones when we're talking also. It looks like, are they not being shared? It looks like Sean's screen is the one that's featured.
Angel, can you go to the view and here? Let me stop it and start it one more time, I guess. But
there we go.
Oh, okay. Let me try it one more
The
time.
wonders of technology. Thanks for bearing with us.
I'm watching your guys' video on a 30-second delay here, so here, let me know when it comes back up, Angel. And
Okay.
Are you in presentation mode?
yes.
Push over one. I'm still not seeing anything.
Back to their introduction slide.
Nope. Whatever you did before, do it again.
I think it just. Oh, they're just. Stop the share one more time here. Let me know when the presentation window goes away for you, Angel.
It's gone.
Okay, sharing the screen again.
If it means anything, I can see it.
Yeah, I don't know why it's not appearing in the room down there. You're still not seeing it, right, Angel?
No.
I don't know if it's a bandwidth thing or not, but we're seeing it.
He is. No? Hey Sean, go to share.
Hey,
Did you select on it specifically, or?
I'm sharing the whole screen. We're seeing it. Unfortunately, no, we're going to be on the 30-second delay because of the webcast video. So, Angel, could you share your screen with Teams, Angel,
Yeah,
and that way they could follow along
Right.
with that way.
Perfect. Yeah, we can see them now. Yeah, great. Thank you so much. All right, you ready to go? Shall I proceed?
Are we ready to go? Could we maybe keep that little box up with her video? I think that might be helpful. Whoever's speaking, that'd be great. Thank you.
All right, next slide, please. Okay, great. So I'm just going to give an overview of what we're going to be speaking about today. So I'm going to start off by providing some definitions, a little bit more detail than Ms. Pines provided on maternal mortality. Then I will proceed to share some data. I will also present our pregnancy mortality surveillance system that's used in California, as well as talk a bit about our California Pregnancy Associated Mortality Review, which are more in-depth reviews to inform quality improvement and other prevention activities. Then I'll turn it over to Dr. Gregory, who's going to present more information on how the California PMAR informs action and the wonderful work that the California Maternal Quality Care Collaborative has been doing in partnership with the state, which we hold up highly and really appreciate. And then it's going to come back to me, and I'm just going to wrap up with a little overview of some of our programs at the state level. Before I dive in, though, I do want to just acknowledge today that though I'm going to be sharing some data and statistics, that we really want to acknowledge that these figures represent individuals and the loss and suffering of families. And so I think that's really important for us to not distance ourselves too much, but we're sharing it, in the hopes that it will inform prevention of future deaths. Next slide, please. So this slide provides the context for maternal outcomes. So this is based on 2021 data among 3.6 million births nationwide, and it shows that thankfully maternal deaths are rare. That's the far line in the far right-hand side of this colored row. But complications are not uncommon, and that's a really important takeaway, and it can inform some of our prevention work. Next slide. So in terms of definitions, and this is directly related to the data that I will share today. So the largest circle on this slide, pregnancy-associated mortality, these are deaths due to any cause during pregnancy or up to 1 year after pregnancy. And the deaths may or may not be related to pregnancy. So for example, this is where motor vehicle crashes would be captured among pregnant individuals. The middle-sized circle there, pregnancy-related mortality, these are deaths during pregnancy and up to 1 year after pregnancy that are related to the pregnancy, whether it's a complication of the pregnancy, an exacerbation of an underlying illness due to the pregnancy, or some sort of chain of events due to the pregnancy that resulted in the death. And this is the definition that is used for surveillance at the CDC and by California, though our methodologies are a little bit different, and I'll talk about that shortly. And then the smallest circle here, maternal mortality, is again a subset of pregnancy-related mortality, and these are deaths related to the pregnancy itself or its management, but only up to 42 days after pregnancy. And this is a measure that's used for international statistics to compare nations, etc., and a little easier to implement due to the more narrow data sources that are used. Next slide. So this slide shows the resources that are available at the state at the link below. The first column there indicating information on California's pregnancy mortality surveillance system. I'll be sharing more about that today. There's also additional information on our website about the more in-depth pregnancy-associated mortality reviews that have occurred in the past or they're in progress. And we also have data dashboards where our data is available online, both at the state level and when numbers allow, also at the county level. Next slide. All right, so I'm going to start by talking about California's pregnancy mortality surveillance system, which I will refer to as PMSS. Next slide. So PMSS in California started in 2018, and the goal is to identify the cause of death and timing to death. Also to identify pregnancies that are related to pregnancies. So that middle circle that I showed when those definitions, this is to provide overall surveillance numbers so we can track trends and how our data is looking at the state. It also informs our more in-depth reviews in areas that we need to dive in a little deeper if we're seeing areas of concern. Next slide. So this is an involved slide, so I'm going to talk you through this. I think it's really important to understand how does California do surveillance for maternal deaths. So starting on the left-hand side here, we start with death records. We link those with birth records and fetal death records. That results in identification of 70% of pregnancy-related deaths. There's additional linkage then to clinical records, medical records, and then finally, we also look at ICD-10 codes as well as the pregnancy checkbox, and that adds an additional 5% of deaths in a cohort. All of these deaths then are compiled into a pregnancy-associated death cohort, and coroner records are pulled in order to identify the timing of the death and to confirm pregnancy status. And then because we're looking at pregnancy-related deaths for surveillance, we exclude pregnancy-associated deaths, which are listed here. And so there's some other exclusions in our methodology. And then that final cohort of deaths goes to an expert committee to make a determination of whether the death was related to pregnancy. Next slide. All right, and now I'm going to share some data from our California PMSS. Next slide, please. So before I jump into the data, this is just a reminder that the maternal mortality ratio, again, often used for international and also at the U.S. level data comparisons, are deaths related to pregnancy up to 42 days after the end of the pregnancy. And the data sources used for maternal mortality ratios include death certificates and ICD-10 codes, whereas the pregnancy-related mortality ratio goes up to 1 year after the end of the pregnancy and uses many other data sources in California, including those listed here, and those records go to committee to ensure pregnancy-related status. Next slide. So I believe this was shown earlier, some version of this by Ms. Pines. So this indicates pregnancy-related mortality in the U.S. and in California, with the red line at the top representing U.S. statistics and the blue line below showing that California has trended below the U.S. statistics since 2012 and previously, which is good news, particularly considering the more comprehensive nature of our data collection and additional data sources that are used to make sure that we don't miss any deaths. You will see that U.S. statistics are not available yet for 2020, but in California there was a bump due to COVID deaths in 2020, and the dashed line indicates what our death rate would look like if we excluded those COVID deaths. Next slide. This slide shows the pregnancy-related mortality by county in California. And for the counties that had sufficient statistics available to be included in a county-level map, you can see as the blue color gets darker, the rate of deaths goes up. And so we can see that, for example, in the Central Valley, there are some counties that have high pregnancy-related mortality, including in Kern County, which experienced 11 deaths during this 5-year period. Next slide, please. All right, so to inform our prevention interventions, it's really important to consider the cause of death and the timing to death. So this slide shows that the leading cause of death in California is cardiovascular disease. Another takeaway from this slide is to recognize, as was mentioned earlier, that most deaths happen around the time of birth, and that's that medium color that says 0 to 6 days. That's where a large percentage of the deaths occur. However, you'll also see, at least for cardiovascular disease in particular, about a third of those deaths occur after that 42-day period in the postpartum period. And so this is one of the reasons that it's really important that we take our surveillance out to 1 year post-pregnancy. Next slide. All right, so now we're going to look at pregnancy-related mortality by race ethnicity. As was shared earlier, The most concerning and stark race ethnic disparities are experienced by the Black birthing population. You can see these are 3-year periods of time. So 2012 to 2014, that disparity was 4 to 5 times. It went up to 5 to 6 times in 2015 to 2017, and has thankfully come down again to 3 to 4 times. The other thing to point out here is that we also see some slight increasing trends among Latina and Asian populations in terms of disparities. Next slide. All right, so here we're looking at pregnancy-related mortality by race, ethnicity, and cause. And this analysis indicates that across all race ethnic groups, cardiovascular disease remains the leading cause of death. There are some differences. There are small differences if you look at these subgroups that could inform some of our work. Next slide. And then this is the last data-related slide for our surveillance. And so this shows pregnancy-related mortality by community conditions, and this uses the California Healthy Places Index, which is a validated measure of community conditions at the census tract level, social conditions that are associated with health outcomes. So things like housing indicators, economic indicators, access to foods and healthy to parks and those sorts of indicators. And what you can see here, Q1 being the most advantaged communities in dark green, and Q4 in navy being the least advantaged communities, that as community conditions worsen, the risk of pregnancy-related mortality and those ratios go up. For 2018 to 2020, you can see that there are the most advantaged communities were protected and had lower rates of pregnancy-related mortality during the pandemic. Next slide. All right, so now I'm going to do a little overview of the pregnancy-associated mortality review before Dr. Gregory shares a little bit more detailed information on this topic. Next slide, please. All right, so California's PERMAR began in 2006, and the idea is to confirm pregnancy-related status, look at causes of death, and identify opportunities for prevention. The committee looks at contributing factors and improvement opportunities across 5 levels: the patient or individual level, the provider level, the facility level, system level, and community. And those recommendations are then aggregated across multiple cases that are reviewed to inform recommendations and action. Next slide, please. So it's important to keep in mind what maternal mortality review, what it is and what it is not. And so it's an ongoing, anonymous, confidential process that is guided by rules and policies and methodologies that ensure that the process is applied in a consistent manner over time. The intention is to inform prevention interventions, and related, it's important to keep in mind what maternal mortality review is not. It's not a mechanism to assign blame. It's not a research study, and it's not a replacement for other types of review of morbidity and mortality, such as at a facility level. Next slide. So this is an overview of the steps in the PERMAR process. So as was mentioned on that detailed slide that I showed earlier, the cohort of pregnancy-associated deaths is identified. Inclusion and exclusion criteria are applied. And I might just note here that historically, California has looked at some pregnancy-associated types of deaths, such as suicides. So depending on what the intention is, we may continue to include some pregnancy-associated deaths in this. But certainly for surveillance purposes, we narrow it down to pregnancy-related deaths. And then, once the cohort of deaths are identified, case summaries are prepared with a multitude of data sources that I listed earlier. Those case summaries are taken to committee, and the committee reviews them to identify the cause of death, pregnancy-related status, preventability, and contributing factors that can inform quality improvement and other prevention work. And then there's a last stage there where all of that data is then analyzed and reviewed to inform action. Next slide, please. So this slide shows it's a process. The PROMAR process takes time. In year one, we identify those pregnancy-associated deaths, confirm timing and pregnancy status with coroner reports. In year two, all of those record abstractions happen and the case summaries are compiled for committee review. Data is compiled that can be displayed on our dashboards for surveillance purposes. And then in year three, additional analysis happens to inform recommendations and dissemination of those products and partners that we might want to engage around action based on those recommendations. Next slide. All right, I'm going to turn it over to Dr. Gregory.
Thank you. Karen, and I also want to acknowledge the Ms. Pine's presentation. We have to remember that we are looking at data related to people's lives, and I also want to acknowledge that it impacts the reviewers as well. It's a humbling experience. It's an honor to be a part of it, but sometimes it's very emotionally intense. And so with that, I will sort of share how we take this information and try to make a difference. So next slide. In the same way that we acknowledge the mothers that are no longer with us, I want to acknowledge the team that does the work. It's a very multidisciplinary, energetic, and empathic, and extremely smart team that I'm honored to be working with. Next slide. So we get these reports, and then we summarize them ourselves. And then the first thing we do is we ask ourselves, was the death pregnancy related, and what was the underlying cause of death? And 3 reviewers usually weigh in, and then the entire committee votes. And if we decide that it is pregnancy related, we then determine what the underlying cause of death is. Now, if you look at this form, we've sort of broken it down into the major categories, and there are some obvious ones where if it was an amniotic fluid embolus that only happens if there's amniotic fluid, clearly that is pregnancy related. If it's hemorrhage and it's related to a placenta accreta or atony or a laceration, that's also pretty obvious. But some of the others, like cardiovascular disease, sometimes we have to decide if it was a congenital cardiovascular disease that got worse because of the hemodynamic changes of pregnancy, or infection really causes us to, put on our thinking caps. If you remember that, the fetus is actually a foreign body. And so the mom's immune system goes through significant changes in order to host this foreign body. And sometimes those immune changes can impact how they react or respond to normal infection. And so all of that is part of what we're thinking about when we're reviewing these cases. Next slide. And so once we decide that it's pregnancy related, we want to look at the contributing factors. And the contributing factors are, again, multifactorial, and it could be at the patient or family level, the provider level, facility, system, or community level. And as of 2021, we are now also asking ourselves or the committee to weigh in on whether or not they felt that discrimination contributed to the death or if COVID pandemic contributed to the death. And here we're actually looking at it by year because you couldn't prevent it by vaccine if the vaccine wasn't quite available. And then we also are considering, as the evidence evolved for how to treat it, we really had to come out very strongly as a profession because they weren't allowing the vaccine, they weren't allowing some of the medications, and they weren't allowing some of the treatments like proning to pregnant women. And we had to come up and make a really strong case that you have to save the mother in order to save the baby. And that we'll sort of worry about these downstream implications later. And it took, a lot of obstetricians and ACOG and our subspecialty societies to make this case, but we eventually were able to get pregnant women treated, and it did start to make a difference. But then the next question is, well, if there were contributing factors, what specific and feasible actions might have changed the course of events? And then, was there a chance to alter the outcome? And this is where that preventability concept comes up. And I'm going to talk a little bit more about the nuances of that as we go on. Next slide. Okay, so this is the fancy slide that was supposed to be animated, and I apologize for that. But at the healthcare provider level, I'm going to actually switch over so that I see it the way it was supposed to be presented. Just a second. At the healthcare provider level, the things that we're asking is, was there a failure to screen? Was there a delay in treatment? Did the lady show up and there was an elevated blood pressure, but it wasn't recognized? Did the lady have heart disease and was seen by an OB but not referred to a cardiologist? Or she was referred, given medication, but she didn't adhere to the protocol? Was there a lack of continuity of care or poor communication? With regard to healthcare facility factors, was there standardized policies or procedures or a lack of skill or inadequate or available equipment? And these sound like pretty obvious things and, oh my God, that's a problem. But this goes back to the preventability. And I'll give an example, and I like using the hypertension example because especially among clinicians, everyone knows that. When we trained in medical school, a medical emergency for hypertension was a blood pressure of 200/120. Well, in pregnancy, that number is 160/110. In medical school or with people with known hypertension, they can tolerate those elevated blood pressures for relatively long periods of time. In pregnancy, that's not necessarily so. And it wasn't until we put together hundreds of cases across multiple states that we started to see that, this is an opportunity. If we start treating blood pressure more aggressively earlier, we might be able to make a difference. And so the CMQCC and ACOG and other state agencies actually came up with this recommendation that if there's a woman who is pregnant, or recently pregnant, who has a blood pressure greater than or equal to 160/110, that blood pressure needs to be lowered and treated within 30 to 60 minutes. So while it looks like it was neglect, it actually was just in specialty and in ignorance. It took a new evidence and a new policy recommendation to make this change. And now we've seen that we've been able to decrease the number of deaths, because there was a time when preeclampsia was the leading cause of death, and now it's like third or fourth. So we've been able to make a difference, and we feel so strongly about it that it's now going to be a quality metric by the Joint Commission, where every woman who has elevated blood pressure will be tracked to determine if they were treated in a timely manner. And so this is an example where standardizing policies can lead to improvement in care and decrease in disparities, because Black women have higher rates of preeclampsia. Then we look at system factors. So examples of system factors might be they didn't have insurance or they lost their insurance. In some states, you have to update your Medicaid every 30 days. So if you don't update it every 30 days, you can fall out of care and then miss an appointment. Was there inadequate coordination between the hospital visit and the outpatient visit? Was there poor communication? We are really adamant about making sure that people are being communicated in their language of their preferred language, and it's not always clear that that's happening. Is this an example of structural racism or biases and discrimination? And we talk about discrimination and we always assume that it's racial, but the things that are starting to come out through the reviews is there's also discrimination against obesity, there's discrimination against people who use drugs, there's discrimination against disability. So there's a lot of subtle discriminations, and many of these interrelate, but we're trying to be sensitive to all of them. and weigh in to the extent that there's a implicit or explicit bias, so that we can help raise these discussions and start talking about them and making changes. Examples of community factors have already been alluded to by the environment, and we're using the Healthy People Index as a measure to standardize. Each case is evaluated based on where the woman lives. And then, again, we're looking for structural discrimination. And then finally, patient factors. And we don't want to blame the victim. I understand that. We all understand that. But we do understand that there are patient factors, either their behavior or their clinical conditions, that put them at increased risk. So if they live alone, if they're socially isolated, if they're, uninsured, if they have unstable housing, we know for sure that these are risk factors for excess morbidity and maternal mortality. If they have mental health conditions and they're not taking their medicine, or chronic diseases, substance use disorders, all of those contribute to a maternal mortality. Or delay in care. If they don't seek care, or seek care but then don't adhere to the treatment, that will impact their risk for morbidity and mortality. So, next slide. So when that goes to the concept of preventability, and I think that the context is really important. Using the preeclampsia or the high blood pressure example, if you have a headache and you don't go in and then you have a stroke, we would say that that was preventable, but it doesn't necessarily, but it was preventable at the patient level, not at the health system level. If you have elevated blood pressure and the doctor or the doctor saw it, there was a time, in fact, I've written a paper about it. So, for example, you have an elevated blood pressure at the time that your epidural is placed. Frequently, we would discount that and say, oh, it's because of pain. And it wouldn't count as that first elevated blood pressure. Well, we've done a study that shows that 30% of those women will go on and develop preeclampsia. So maybe we should be paying attention to that first elevated blood pressure associated with pain. And so that would be one that might be a health system issue. In some of the smaller hospitals, if you have an elevated blood pressure, a doctor had to be the one to push the IV medication. Well, we realized if you don't have a doctor in house, or you only have one doctor and that doctor is doing a delivery or in a C-section, they may not get there in time to do that timely administration of blood pressure. So we've encouraged policies that allow a nurse to administer the medicine without a doctor being present, because it's a safe thing for a nurse to do. It's within her scope of practice, and it was a barrier preventing timely care. So again, these are examples that you don't really know about until you start trying to do things to scale. And again, we would have said that that's preventable because the hospital policy didn't allow the nurse to do it. But now we've changed that so that nurses can do it. And so again, we're seeing less of those preventable deaths. Suicide, that we actually score that sometimes as preventable, even though in fact it was a patient factor that was deliberate. And the reason why we would say it was preventable is maybe the patient was manic depressive and she was in a depressive state and wasn't taking her medication. So when you see preventable and you see this large number, please understand that there's a lot of different levels and nuances to preventability. And our goal is to, I don't know that we can ever get to zero, but our goal is to get to as low as possible. And therefore, we're being as generous as possible when we start thinking about how preventable something is. And Karen has pointed out that it's 3 years almost just to get to the point where we're doing a review. And so that just reinforces not only how labor intensive it is, but how emotionally intensive it is for each of the people who are involved with that chart review. Next slide. So once we've got all this information, we've decided it's potentially preventable, then we have to say, well, how could it have been prevented? And at each one of those levels, we would say at the hospital, at the provider level, the hospital level, the system level, and the patient level, these are the ways that this particular death could have theoretically been prevented. And so, for example, with the elevated high blood pressure, the medication could have been given sooner. And again, we feel so strongly about it now that it's going to be a Joint Commission quality metric for the upcoming year. Next slide. So how do we make these recommendations and then get them out to scale? Next slide. This is where we acknowledge the CMQCC. Someone earlier said it takes a village to tackle this problem, and they're absolutely correct. And this village includes multiple stakeholders, including state agencies, hospital membership or associations, key leaders at major health systems, professional groups such as the American College of OBGYN and the Association of Women's Health Obstetric and Neonatal Nurses, a College of Nurse Midwives, and then public and consumer groups have become more and more involved. And I think that this is great because it's really a public health problem. Every time I pass a billboard that tells me what to do with a stroke, I'm wishing that billboard was the early warning signs for, maternal mortality or maternal morbidity. And I'm sure that one day that will be. But in the meantime, there is a website by the CDC called Hear Her, which actually goes over what those warning signs are. And we're trying to do a much better job of communicating that at the time of discharge. And then lastly, health plans. Health plans have to be in the game too, because a lot of these morbidities either cost them or by covering, one of the new mandates is to cover pregnant women for a year postpartum so that we can help get them better after the pregnancy so that we're not tracking them and finding them in our reviews, but also that we're helping them preconceptually or interconception for the next pregnancy to optimize their health. So this is a multi-stakeholder problem and therefore a multi-stakeholder solution. That's okay. Next slide. So CMQCC has developed 8 toolkits since we started in 2006. And the hemorrhage toolkit is already on its 3rd revision, I believe. And that just, emphasizes that medicine is iterative. It is changing. There are new medications that come out. And therefore, we want to update our guidelines and policies so that we're practicing state of the art. And then that we're getting that information out to the smallest medical center. Next slide. So after the review, we developed toolkits. And then we start having collaboratives to share the information. And what's really important about the collaboratives is, if you guys remember, everyone says, it took 17 years before we really inculcated low-dose aspirin for treatment of heart attacks and stroke. Well, we're trying to short stream that and not take 17 years. But we do realize that when you bring out new policies and procedures, you do have to bring people on board. And so usually there are the early adopters and then the middle people and then the end. And the early adopters help us understand what the barriers are in local systems that need to be overcome in order to implement these things. So we talked about the fact that there was a time when a doctor was the only one who could do IV medication pushes. And now we've liberalized that for nurses. And you can imagine that is easy to do at an academic institution, but it's a little harder to do at some of the rural sites. So again, by partnering those who have adopted with those who have yet to adopt, that is the two-way nature of the collaboratives, and that is how we're able to implement these changes at scale. But it does, again, take a village. It takes the hospital will, it takes a CEO to say that this is important. We need data people at each hospital to do the data and the feedback to show them how well they're doing and how they're improving. We've got to get the message out to people. Right now, we're trying to get low-dose aspirin out to people at risk for preeclampsia. Studies have shown that decreases the risk of preeclampsia by about 30%. But we're fighting a message that has been widespread forever that pregnant women aren't supposed to take aspirin. And so it's a hurdle that we have to overcome. And again, you've got to bring in the public to teach them about that. So engaging pregnant women and recently pregnant women is another important part of this. So again, it's multifactorial, and it takes help and input at all levels. Next slide. So one of the things that you can't pick up a newspaper and not talk about these days is birth equity and implicit bias. And so we're trying to tackle that now. One of the ways that it's being addressed through CMQCC is by looking at the cesarean rate in low-risk women. It's not a secret that the United States has a higher than we believe necessary cesarean rate, and so we've been actively working to reduce that rate. As the rate has come down, it's become apparent that the Black women have a higher C-section rate than white women. It's not 100% clear why that is happening, but what's disconcerting about that is that women who have a C-section have higher morbidity and higher mortality. And so this could be one of the underlying causes that's contributing to the disparity. And so we're specifically going to focus at the next intervention at trying to lower the disparity in C-section rates using an equity lens, and trying to make sure that we're, treating women respectfully, with dignity and shared decisions, addressing any and all microaggressions. And, it's multifactorial, trying to address where the subjective parts are happening, because there are plenty objective parts that we think if we've standardized the care, we can lessen the disparities. Next slide. And this is being done with a community birth partnership. We are hopeful that by engaging doulas and midwives that they will be part of the solution. One of the things that's not clear, that will be a collaborative learning initiative, is trying to figure out how to best integrate doulas and midwives into hospital care. I think the midwife piece we're a lot more comfortable with, but the doula piece will be a learning opportunity for all of us. And then a lot more people are actually trying to have births at home, but then they come into the hospital at the last minute, and we need to make sure that we have developed out-of-hospital transfer tools to make this a more easy transition. Next slide. I briefly mentioned the low-dose aspirin, but you will be seeing that as the next big public health campaign by CMQCC and other community partners. And I think that should be it for me. Next slide. No, there's a couple more. So this is just bragging on CMQCC and the accomplishments from California Maternal Mortality Review Committees. We started meeting in 2006, and you can see after we started meeting and developing the toolkits, we noticed a significant drop in the maternal mortality in California that is in contradistinction to what's happening nationally. And each one of those call outs is what, the toolkits that were brought on board at that time. Next slide. And this is showing the same information another way, but just bragging on the milestones of the California Maternal Mortality Review Committee. And I think we've got a lot of work to be proud of, but we are also humbled by the fact that there's still more work to be done. Next slide. So I thank you for the opportunity. I'm sure there'll be questions, but we're going to end now with other things that is being done to promote health in California.
Great. Thanks so much, Dr. Gregory. So I'm going to talk a little bit about some of the maternal health promotion activities happening at the state. Next slide, please. So with the Maternal Child Adolescent Health Division at the State Health Department, we have a number of activities in the works that influence maternal health. So at the top here, you see infrastructure and capacity building types of activities. And so I'll just kind of quickly go through these. So each jurisdiction, each county in California has a local maternal, child, and adolescent health program. And within their scope of work with us, they can choose to develop locally driven or some suggested state level activities to promote maternal health. The regional perinatal programs of California, these coordinators, these RPPC coordinators, work with birthing hospitals within their region to support quality improvement efforts, as well as to address, as mentioned earlier, systems such as around transport or maternal levels of care, helping with that relationship building between hospitals so that lower levels feel supported, and those types of activities. We have a number of subject matter experts in the areas of nutrition, physical activity, breastfeeding, preconception health, gestational diabetes, and these staff work with our programs and programs of partners to bring the latest information to those activities, and also within our own state level programs. We have a fetal infant mortality review effort. And then coming very soon, a mental and behavioral health initiative is new at the MCH division, and this is getting staffed up right now. These are new funding for this, where we will have staff assigned across the life course, including the pregnant population, to address maternal health outcomes in the areas of mental and behavioral health. And then we have some programs that are geared towards specific populations. So I'm going to talk a little bit more detail about our Black Infant Health Program and Perinatal Equity Initiative in just a moment. But also to note, we have an adolescent sexual health education program, which provides fundamental information for individuals before they enter their reproductive years, or as they are. We have the California Home Visiting Program, which is being implemented now on almost every county in the state, and soon will be available in every county. There are currently 3 home visiting models that are implemented, and there's also an opportunity for counties to implement innovative projects that meet the needs of their unique communities, particularly important for smaller and more rural jurisdictions. And then we have the Adolescent Family Life Program that provides services for expectant and parenting youth. And both the home visiting program and AFLP provide, services to a diversity of populations across the state. Next slide, please. So I want to talk a little bit about our Black Infant Health Program. This program has been around since the 80s and certainly has been updated over time based on the needs, and particularly hearing from our local partners who are doing this work. It's a group model, and that also provides complementary life planning, case management services. And the premise behind the Black Infant Health Program is really, as was mentioned earlier, the weathering impacts of chronic stressors, including racism, on Black birthing individuals. The Black Infant Health model is intended to mitigate some of those weathering impacts on the health, hopefully before pregnancy, if not, during pregnancy and for subsequent pregnancies. And that's done by promoting social support and empowerment, and giving Black birthing individuals information and skills that they need to manage stress. And we do know that the program has positively resulted in better understanding and use of effective strategies to manage stress, stronger connections to heritage, and connection and support within their own Black women within their communities, and empowerment to make behavior changes. And then we're really excited about the Perinatal Equity Initiative. This came about in the Budget Act in 2018. And the intention of the PEI is to really round out the Black Infant Health Program within the jurisdictions where BIH is located, to provide additional services that those communities determine are needed to supplement BIH. And so some of the initiatives that are being implemented include doula services, the Fatherhood Partner Services, a really popular initiative, and some, as was mentioned earlier, some of them are also working with provider and health systems on addressing implicit bias. Next slide, please. And just to recognize that a number of programs across the state health department also influence maternal health outcomes, is listed here in a variety of ways. And then I think it's also important to recognize, other state departments, such as the Department of Social Services, also funds home visiting programs across the state. And as was mentioned earlier about Medi-Cal, the Department of Healthcare Services with CalAIMM has a real focus now on maternal health outcomes and is doing a variety of things in terms of benefits, like really trying to be supportive of birthing individuals and the interests and types of providers they'd like to see, support from doulas and midwives, for example, but also recognizing that social drivers of health and the importance of providing supports to individuals who are at higher risk for poor maternal outcomes by not just providing medicine, but providing other real supports to individuals. And next slide. I think it's just our contact information. Yeah. So happy to take any questions. And again, appreciate the opportunity to share this information with you all today.
Thank you to Dr. Ramstrom and to Dr. Gregory. We really appreciate hearing from you. If we could just have the lights come back up in the room now that the presentation is down. And are there any questions from board members of Dr. Ramstrom or Dr. Gregory? Dr. Hawkins.
So, thank you very much. So I have a question. Can you hear me? I have a question that relates to provider education as we relate to licensing physicians and monitoring physicians. So this is a very complicated presentation. Clearly, this is a statement that could have been given in a weekend or a week with a lot of different breakout sessions to have different folks who are part of that village see how they can actually help address improvements in this problem. So I appreciate the complexity and appreciate the science that's being used to try to help us address how to get to some solutions. We don't want to forget that very distressing slide where Kern County was in that dark blue area where the highest group of maternal mortality in the state. So it's been stated, it takes a village. And I want to make another statement that a rising tide lifts all boats. There's been some emphasis on certain groups of individuals with very bad statistics, those in Kern County, black women. But if we address the problem that relates to any group of women, it will help all women in this particular area. So that needs to be emphasized. So my question about physician education, realizing there are doulas and there are midwives, what's happening with the education, the emphasis among physicians in obstetrics and gynecology training and in family medicine? And I know Dr. Beverly is involved in the American College of Obstetrics and Gynecology. She's not involved in family practice, but there probably can be some comments related to how we're prioritizing and addressing the education of physicians in this very, very complicated process with a lot of moving parts, but yet a very, very important issue for us to try to get improvement in.
I can take that. One, it's interesting because I'm watching a lot of the discussions about MOCs, but maintenance of certification. Every one of these toolkits or some version of the toolkits or the guidelines are part of the ACOG's maintenance of certification. So, and I think it's important, especially since some of the evidence is changing and what we may have recommended 10 years ago, we're changing what we're recommending now. So by being required to read the article and take the test, we know that every OBGYN has been exposed to it. We've been partnering with family practice, and most recently, actually, we have an emergency room physician on the Maternal Mortality Review Committee who fortunately is very high up in the infrastructure of that society, because what we're finding is some of these women are coming into the ED, but again, because the ED is used to 200/110, they're not alarmed at that blood pressure of 160/110, or they may have not asked, was she recently pregnant? Because if she comes in postpartum, then again, she doesn't get that urgency. But we are partnering with the Subspecialty Society for Emergency Medicine so that we're getting the message out for both sepsis, treatment of preeclampsia, and heart disease, because those are the ones that a non-OB is more likely to see. There's also a huge collaborative that has recently been formed with the American Cardiology Association, and so we're getting the word out to the other practitioners. But I think that from a policy perspective, that having medical care paid for that full year of pregnancy and postpartum is really important. And the other thing that's really important, which we haven't been able to impact, is that we have to get people interested in taking care of pregnant women with medical problems other than maternal fetal medicine people like me, and be willing to take the payment or find a way to pay them more. I personally feel, and this is my opinion, not as the PAMR head or representing the state, I personally feel that if you provide obstetrical services, you should have a subspecialist of every specialty in that hospital who is willing and able to see a pregnant or postpartum woman. And there are some hospitals where that's just not true, and the only person managing them is either the ED guy on call or the OB on call.
Thank you very much. That's very reassuring for an improvement in our outcomes.
Additional questions? Okay, we've got three, so we'll go to Dr. Balot first, then Dr. Helzer, and then Mr. Watkins.
Thank you very much. Excellent presentation. Lots of information. And I had a couple of questions. We talk a lot about shared decision-making in medicine, and how much have you learned regarding health literacy and its impact on this whole notion of shared decision-making, which is really a challenge for any socioeconomic group of individuals? That's my first question. And the second one is about I believe you made a comment about you were able to work with hospitals for midwifery, but I'm thinking about the challenge of, so there's these wonderful doulas. What is the resistance as to classifying that group of individuals to come into hospital? I'd just like to hear your comments on those two items. Thank you.
I'm happy to weigh in on, especially on the first question. So I would say one of the main strategies, if you will, around health literacy is really to ensure that individuals who the pregnant individual or recently delivered individual feels most comfortable to receive services and information from are available to them. That's a really important key that we've seen with our comprehensive perinatal services program, with our home visiting programs, with other types of even in-office supports, ensuring that whether it's peers or individuals from the community that can be directly educating and supporting and developing relationships with those individuals who are either still pregnant or recently given a birth. In terms of some of the work around doulas, I think there's a lot of effort in terms of at DHCS. There's a work group I know. There's some other efforts to kind of support and look at policy related to doulas. I think a lot of that's still in the works. I will say that some of the work that the Perinatal Equity Initiative is doing is really supporting within the community recruitment, and also supporting those doulas to figure out, well, how do I do it? How do I get paid by Medi-Cal? How do I actually go about getting into the hospital? And so there are some of those community level efforts to support doulas, but I agree. I think there is more room to go and sort of some more conversations to have around how do we shift even the thinking, even within institutions, to see doulas as a support, and having a birthing individual coming in with that support is a value. And I think it's still in the works.
Thank you. Madam President, just one one follow-up
Can I just
on that.
comment on that,
Oh,
on
yes.
the doula issue as well? I think that we were really set back by COVID, because there was a time when it really didn't matter. If you were in labor, you could bring whoever you wanted. Nobody cared. It could be your mother, your father, your sister, your brother, your doula. It didn't matter. And then COVID hit, and then that sort of like, oh my God, we can only have one support person. And then people liberalized back and said, okay, you could have two if the second person was a quote support person. And most hospitals don't care if that's a doula or not, or how that doula is defined. However, as we start using this as an opportunity for helping patients to advocate for themselves, I think, I hope I'm saying it's Denise, I know it's Miss Pines, but she said something that I thought was really important today, and that was we have to stop being transactional and be more interpersonal. And I think that that's going to be the key for the doula, is she's got to be interpersonal not only with the mother that she's caring for, but with the hospital personnel that she's interacting, or that they are interacting with. And I think that that's the key, and we're all just looking for better outcomes. So I think it's just a one-on-one opportunity that's going to happen in each room and at each hospital.
Thank you very much. And if I may, Madam President, one follow-up on the doula, and I'd like a kind of a good education here as to regarding doula and the uptake within different communities. Many years ago, I was involved a lot in OB and down at County Hospital. And so it was largely Latinas. And so that the doula took up very well. It fit what was the cultural construct and norm. What can you say about Black women and their ability and their comfort? Who do they want? Would this be something? Do you have data on that?
I can share, I don't know that we have quantitative data, but we certainly recognize, so the perinatal equity initiatives in communities where that's being implemented, there is a lot of interest. And those programs are recruiting from within the Black community and supporting and getting up to speed doulas to support Black birthing individuals. And it seems to be very well received and of interest. And I think there's more work to be done there. I think, in fact, I think we would really love to be able to have every PEI program do this work. And so we're learning. It's a new initiative, but we have recognized that it's been very well received. And people want to be represented by who they feel supported by, and who they feel they want to feel heard. And it's been very successful so far.
Thank you.
Thank you, Dr. Helzer, and then Mr. Watkins.
Thank you. And thank you, Dr. Ramstrom and Dr. Gregory, for your presentation. In my practice as an anesthesiologist, I take care of patients from time to time with severe obstetric hemorrhage. And I've found in recent years, the toolkits and protocols for dealing with these patients to be very valuable, like the CMQCC obstetric hemorrhage toolkit. I'm wondering if you could comment on any work being done with hospitals and blood banks to make sure that small hospitals in the community have the resources needed to respond to massive transfusions in obstetric patients.
Well, what's happening is there's a call for what we call maternal levels of care, so that you're actually being cared for at a risk-appropriate site. Mm-hmm. And so level 2, 3, and 4 should all have a blood bank. And level 1 is, either a rural hospital or a birth center, and they're not required to have a blood bank. But then they should have relationships for rapid transfer. So then that brings up home birth, which, they don't have a blood bank either. So, if you're an obstetric hospital, and I don't know what the delivery volume is, but there is a specified volume that qualifies for level 2, and based on that, there should be a blood bank available.
Thank you.
Mr. Watkins, did you have a question or comment?
But unfortunately, you can be really healthy, really low risk, and still hemorrhage, and that's the problem.
All right, Mr. Watkins?
Yes, is this working? Yes, I just wanted to say thank you this is a lot of information, but it actually all adds up. And my questions are more with the view of how do we make this board better in addressing some of the issues that arise out of these things. And so I have a technical question and just a broader question. My first question is, when you talk about preventable, that strikes me first. And you talk about do you review medical records when you assess what was preventable in terms of the facility, not having the appropriate equipment, or on the side of the physician not seeing certain things? Do you actually use the medical records, and do you apply a standard of care?
So the medical records are abstracted by a trained nurse abstractor with experience in OB. I, as a committee person, only see what she abstracts because, of course, this is all de-identified and confidential. Now, they will frequently cut and paste, what do you call it when you black out something? Redacted information. And from that, so for example, there might be a case where it was, they're asking for instruments that are appropriate for obesity and they don't have access to them. And that might be documented. The only record that we see for sure, again, it's redacted, is the anesthesia record if there's concern either about the anesthesia or the fluid management. So that is the only piece that's always part of the record. But and I do miss, quite frankly, with the handwritten charts, because there was always a little more nuance that was either there or not there because they didn't write anything at all. Then from the EMR, the abstracted data from the EMR. But yeah, we are inferring, there's enough subspecialists and multi-specialty people for us to infer whether or not we thought the care was appropriate or what we thought was missing.
Thank you. So my second question is more broad. As you were pointed out, it takes a village, and I saw that everybody was on your partnership list, but I did not see the Medical Board of California, and we are kind of the final stage of the loop in terms of what happens when these things actually arise in people's lives. And I know you like everything is anonymous, and the data that you gather is to inform decisions. And I just thought that there would be, some space for us in terms of seeing some of that trends so that we can improve some of our enforcement activities, especially around the discipline of what is missing, because sometimes we also miss and what needs to be updated. And I just wanted to see how you feel about, I'm being presumptuous, but, us closing that loop, because I just noticed that we went on the partnership list. Thank you.
Dr. Ramstrom, I hope I'm not speaking out of turn, but if you want, I'll be more than happy to nominate you, sir. It's really, getting on this committee is really just a nomination process. And we do want people to have some medical expertise in their subject matter. So be that anesthesia or medicine, family practice. But we have a coroner, a pathologist, we've got blood bank, we've got social workers. I think that your question is very timely, and we would welcome someone.
Well, I'm not a doctor, I think we could discuss that.
You don't have to be a doctor. That's what I meant. We take community people as well.
Yeah. Are there other questions or comments from board members of the various speakers that we've had today? Okay. All right. It looks like we have one speaker from Kern County that may need to speak before we go to public comment. Is that right, Reggie? Is that okay? And so that is. Hold on. Is she? All right, so we have Ms. Letitia Perez, who's a Kern County supervisor, who would like an opportunity to speak before we go to public comment. So is Ms. Perez here? Welcome.
Thank you so much. I really appreciate you being here and having the opportunity to just drive down my street this morning and come and find a bunch of really powerful, smart people, concentrated in my community, thinking about issues that are really important to just the everyday people who live here and make Kern County thrive and make it a community. Kern County is still very much a small town in many ways. We all really know each other. We understand the power structure, right? We have our squabbles. But at the end of the day, we have an incredible philanthropy, an incredible spirit of generosity. And you'll hear from others in this community here in Kern that have taken issues that are of such profound personal tragedy and have made them oriented and directed them to help and build community. And that is authentic, that is real, and I want you to know that what I have seen through that organizing, and in particular these women and also fathers, have experienced things that would break most people. And though they often feel broken, I'm sure, the fact that this is happening here today is really an incredible indicator that not only that the organizing is successful, but that important people, the right people, are listening and taking the time to listen to the human beings associated with, how we decide to be a civilization, right? It's up to us. You're the body. Accountability is totally up to us. It's an inside job. And at the same time, right, to promote who we are in the world and to promote these professions and honor them as they should be. We want to thank you for being here. District 5, we are a remarkable community of a lot of moms. Our third of our Cal State is Latina moms. Is Latinas, comprised of Latina students. 69% of babies born in Kern County are to Latina moms, right? This is our workforce, this is our community, this is our ever-changing society, and those are realities that we should look at objectively, right, and say, here are some gaps, here are some ways in which we educate and empower through information, and help society understand how we balance this power thing, because it's complicated. It's not easy, and a lot is at stake. So I appreciate the courage to take the issues on, to listen, right? Because we learn so much when we listen. And these moms and these communities that have been impacted, particularly in these arenas, have ripped my heart out of my chest, frankly. And every time I see them, my heart just, it gets rechecked and rebalanced about what's important in the world. So God bless you, your hands, your time, your minds. Kern County is a beautiful place, and we are always progressing in many ways. And we appreciate the role that you're playing in that evolution. So thank you.
Thank you, Supervisor Perez. As I mentioned earlier this morning and yesterday, we are grateful for the opportunity to hold this meeting here in your community. It's been very impactful for all of us already, and we're looking forward here shortly to hearing from some representatives from Kern County Department of Public Health and others, from your great county. So thank you for stopping by our meeting. We really appreciate the visit, and again, we appreciate greatly the opportunity to be here in your community, to experience Kern County, to experience Bakersfield, but also to interact with the great people who live here, who've been frequenting our meetings for many years, and we haven't had the opportunity to meet them in person previously. So we're grateful to be here. With that, I think we're going to move on to public comments so we can hear from some of the people in the community, both here and then also via teleconference. So are there people in the room who would like an opportunity to speak now? Please just make your way up to the front here to the microphone. And before you get started, if I may, I do want to thank our speakers and remind the members of the public that this is a conversation with the board, and while some of the speakers may remain to hear because of the way public comment works under the Open Meeting Act, please do address the board members with your comments. Thank you. Okay, please just make your way up to the front here for public comment. We will have another opportunity also after the two other groups of speakers that will provide the local perspectives. Welcome.
Thank you. My name is Dr. Tasinga. I'm the Chief Medical Officer for Kern Health Systems. Kern Health System is the medical managed care plan in Kern County. Our mission is really to improve the health of our members through prevention and providing quality health care. I just want to share some of the things that we have been doing for our members. We cover close to 375,000 members in Kern County. We came to the realization when we started looking at maternal mortality that Kern County had a higher maternal mortality rate than the U.S. as a whole, even though California was lower. So we stepped back and looked at our own numbers at a plan, and we saw that our numbers were higher than the numbers of the United States. So I just wanted to share some of the things we have done after that realization. One of the things we did was we had focus groups in different zip codes to see what was really happening. We found that there are some zip codes that we cover that most of the women don't see the OB doctor during the first trimester. The other thing that we found out is that those women, after they deliver in the same zip code, they didn't have the postpartum visit, which is recommended. And the 15 visits they are required to have throughout the pregnancy, they didn't have that. So what we did is we started a program which we fondly call Baby Steps. And through this program, what we do is once we get a bill that a patient has had a pregnancy test positive, we have staff members who start calling them to get them, to educate them about the pregnancy, get them in to see a doctor, coordinate transportation for them, and also refer them to our community support department where we can arrange transportation, housing, food baskets, and other supports that they might need. And then we also do screening for depression, because knowing the type of patients we have low-income patients. The rate of depression is high, and it's also high in pregnancy. So we screen them for depression, and we also screen them for other chronic conditions like hypertension and diabetes, which are very common in our population. From that, we have another program we call Baby Steps Plus. Baby Steps Plus is for those people who are high risk, either because of socio-economic conditions or because of chronic conditions like hypertension and diabetes. And we have community health workers who go to their homes to visit them and really build that relation with them and be their point of contact. Because some of these patients, we have to ship them down to Southern California because they don't have the doctors here. So we have relationships in Southern California with UCLA, USC, and even CEDARS, so that when we have these patients that we cannot take care of here, we are able to coordinate, either fly them down or drive them down. And when they are in Southern California, we provide housing for the families. The other thing that we have done is we have partnered with our community hospitals really around the CMQCC toolkit. Most of our hospitals now that provide deliveries in the community have implemented the CMQCC toolkit. and they make sure on a quarterly basis that all the OBs that are delivering in that hospital go through a refresher course to make sure they are still up to date for the way the toolkit has been set up. We have also, with AAIMM, we are very excited because one of the things that AAIMM is doing is breaking down some of the barriers around data sharing. Before AAIMM, it was very difficult for us to get data from other community organizations that are taking care of our members. So it made it very difficult, one, for us to identify our members, two, to even try to coordinate because there was no requirement to share that data. So we are really excited with what AAIMM is doing and breaking the barriers down for sharing data so we can take care of our members. And we now have a new Office for Health, Equity, and Disparity, and we are really looking at going into some of the very rural areas of Kern County, Kern River Valley, Ridgecrest, Tehachapi, those places to have focus groups with them to see what are their own barriers. And I just felt that I needed to share that some of the things that the state has been doing, we have taken some of those things and we have started implementing them. We are also partnering with the Black Infant and Maternal Health Initiative. We actively participate with them. And I would just say to the community members who are here that we are looking for many people to reach out to us to help us because one death of a mother for us is too much. And we really want to do whatever we can to bring that down. Thank you. And I would like to give my number is 661-664-5000 at Kern Health System. So if you are a community partner, a community organization representative, and you want to partner with us, we are very open to do that. Thank you.
Thank you. Thank you for sharing all that important information with us this morning, and thank you for being here. Are there others who wish to make public comment at this time? Okay. Is there anybody on the line who'd like to make public comment at this time? We have 3 commenters. Okay, let's go to the teleconference line, please.
Thank you. Eric, your line is open.
I'm sorry, what? 1 second. What, Michelle? No, but I just asked and nobody raised their hand. So we'll go to the line. We'll come right back when we're done in the line.
You ready for me? Hello?
Yes, please go ahead.
Can you hear me?
Yes. Yes, sir.
Denise, I said to Marion this morning, I wonder if she'll wear yellow, and you didn't let me down. So, very interesting presentations. As you know, Marion and I introduced Charles Johnson to this board in 2018. Charles' wife, Kira, died in childbirth at Cedars-Sinai Hospital when a horrendously negligent doctor by the name of Arjang Naeem allowed her to bleed to death, not to mention harming several other women. This board, in its infinite wisdom, gave Naeem only 4 years probation. Charles Johnson came to this board meeting and gave this board hell for that. I see Denise didn't even mention that very public case, even though she left the room in dramatic tears after his speech. So I think we can talk about the problem till we're blue in the face, but you also have to address that these problems will continue as long as boards like this continue to let these bad doctors off with a slap on the wrist. Naeem, who harmed multiple pregnant women, is still practicing because of this board, and his decision was signed by your own Christina Lawson on October 10th, 2018. She herself, a woman who could have weighed in on this horrendous problem against other women. Naeem's probation is already over. I had a lot of trouble hearing a lot of this presentation, so I apologize if I missed something. I've been trying to quickly read through the materials, and I couldn't find if the statistics are California or nationwide. And while I saw some percentages of what kinds of records are searched for with the information, I couldn't find what percent of total records are actually searched. Is every death certificate for childbirth death looked at across the entire state or across the entire country or only certain offices? California's black population is larger than that of all but 5 other states, Texas, Georgia, Florida, New York, and North Carolina. So I'm wondering if you're looking at California's high numbers in regard to race, and then that affects how it's represented in general for the entire U.S., or if all childbirth deaths are looked at, how that affects the percentages. What is the criteria for pulling the death certificates? Are you including home births or just hospital births, et cetera? I know, too, that death certificate information is only as good as the information the county is given, and death certificates notoriously have incorrect information on them. My sister, who died from medical errors, lists causes of death that don't clearly point out that she died at the hands of negligent doctors. A doctor who didn't even treat her submitted the incorrect information. We also know that a patient records are often incorrect and manipulated, so one would have to wonder about looking through patient discharge data, which could easily and with a high likelihood of probability be skewed so as to not have the correct death information on it. I just want to make sure that the numbers are being compiled correctly and other races aren't being underrepresented. But most importantly, one way to stop maternal deaths at the hands of bad doctors is to make sure medical boards like this one aren't letting them get away with it, so we can appease Richard Thorpe and the CMA and keep a high number of working doctors in the state without regard as to whether they're treating patients safely. Thank you.
Thank you for your public comment. Next speaker on the line, please.
Okay, your last comment comes from Marion. Your line is open.
Hello, can you hear me?
Yes, please proceed.
Yes.
Okay, thank you. Hello, this is Marian Hollingsworth, patient safety advocate. Regarding the increase in maternal mortality in this country, it's really sad that women are being treated by healthcare workers who dismiss them. This is a matter of attitude. Dr. Thorpe saying he had to harden himself to the pain is really an indication on how doctors and labor nurses don't take the suffering and preventive measures seriously. Because of this dismissive attitude, more women are dying in childbirth, and women of color are more at risk to that attitude. 30 years ago, when I had my last baby, I told the nurse I had to push, and she dismissed me by saying, "No, you don't." This was my fourth baby, so I knew what having to push felt like. I leveled a stern look at her and said, "Watch me." That's when the nurse ripped open the door and screamed down the hall for a doctor. I still resent the fact that she didn't believe me. If you know Serena Williams' story, you know that she was ignored by nurses when she said she felt like she had a blood clot. She could have died. A nurse even called her crazy. However, if she had not pushed for care, that blood clot could have killed her. And with the case of Kara Johnson, she was allowed to bleed to death in the biggest hospital in L.A. because no one believed her or her husband, Charles, when they were begging for help. The doctor dismissed their concerns and those of the residents who were afraid of getting in trouble with that doctor. On the flip side of these stories, when I brought my late husband to the ER when he had sepsis, he was taken in right away and given treatment. And I was very grateful that he got that treatment immediately because I honestly didn't expect that. The thing is, the doctors and nurses believed him and his symptoms. There was a protocol for that hospital for sepsis. Why can't there be a protocol for labor emergencies as well? The question is, why don't healthcare workers believe patients, especially women in labor? And why don't hospitals have protocols for these labor emergencies? It's like they think women are stupid, that they don't know their own bodies. So with the attitudes of Dr. Thorpe and other speakers who say they have to get used to the pain and suffering and people dying to harden their hearts, so to speak, maybe it's time that healthcare workers care more about their patients. That way, when the patient says something is wrong, that issue can be checked out immediately and not dismissed. You will save lives if you believe women and not dismiss anyone because of their color. And if you save more, and you will save more women if you hold dangerous doctors accountable and not give them lenient disciplines like you did with Dr. Arjun Naeem and the Kara Johnson case. Please believe women and not hold their color against them. Thank you.
Thank you for your public comment. Do we have one more? No more speakers on the line. Okay, we'll bring it back to the room. Are there those that would wish to make public comment at this time?
Hello, my name is Xavier De Leon, and I'm a local advocate with Consumer Watchdog. I'd first like to thank you all for coming down to Bakersfield to sit with us and talk about the maternal infant mortality crisis in our town and throughout the Central Valley. 4 years ago, on April 19th, my life would change forever. That is the day that I lost my entire family and everything that I would know it. as I would know it. Now, as a fatherless father, I dedicate my time along with my fellow advocates to bring change to the Central Valley. Today, I am calling on the board to conduct a survey on maternal health and maternal mortality here in California. I believe this information can be vital in the aid of the maternal health care. I am passionate about the maternal health care crisis that is going on not only in my community, but in the Central Valley, because my family is a part of some of the statistics that we talk about in some of these meetings. In a perfect world, I should not be in this meeting, but I am here today to address the problem in this state that when it comes to babies' rights, my son Malachi was denied an investigation by the medical board and was given a hard time by the Department of Public Health when we tried to file a complaint. Thank you.
Thank you for being here. Next public speaker.
Hello, thank you all for being here today. My name is Mikey Shamak. I'm also with Consumer Watchdog as well as the Justice for April campaign and movement. My cousin April Valentine passed away earlier this year, January 10, 2023. Unexpectedly at Centinela Hospital at the hands of ill-equipped doctors like Dr. Gwen Allen and nurses that she was in the care of. She repeatedly begged and asked for help, and she was dismissed. And the nurses told her that if they continued to call the doctor, Dr. Gwen Allen, that Dr. Gwen Allen would cuss them out. And so we are asking the board today for a report on maternal health and maternal mortality. We're asking you to report on the number of complaints you receive, how many of those complaints are dismissed, how many of those complaints receive discipline, and what kind of discipline. I'm not sure of the number of complaints issued against Dr. Gwen Allen, but I know that from reports online, she's constantly said to be very neglectful, very aggressive, very dismissive, lacking empathy. And these are all things that April and our family have experienced from her. And she's known to have a bad rapport with those in the community, not caring for those in her care, and not committing to the oath that she gave to care for others and care for her patients. April trusted her, and she failed April terribly. She failed our family, she failed our community, and there's an investigation that is open with April, and we're asking that you look deeply into this case. We're asking that you look deeply into Dr. Gwen Allen and what other community members are saying about her. She's not safe to our community. Thank you.
Thank you for being here.
Good morning. I'm Monique Himes. I'm from Bakersfield and a volunteer with Consumer Watchdog. I would like to thank you for coming to Bakersfield. I've participated in many of your meetings in the past few years and sometimes felt like you were not listening to us, but bringing your board meeting to our city has meant everything to us and our efforts to save other lives here in the Central Valley and across California. Sorry. I'm a grandmother. I'm a grandmother that has dedicated much of my time to building a movement here in the Central Valley to address our maternal mortality crisis. On that day, we did not just lose a mother. We lost a mother and a baby. We lost Demi and Malachi. We are doing our part, and we need this department to do yours. We are calling on the board to conduct a maternal mortality report. We want you to report on the number of maternal health and maternal mortality complaints you receive. How many of those complaints are closed? How many of those complaints receive discipline? And what kind of discipline? And how many doctors are repeat offenders? We look forward to your review of the report at future meetings. We are here, all of the parties together in one room. Let's make a change today. Thank you.
Thank you.
Get my notes. This is what maternal mortality looks like in my house. Get my. Oh, okay. Switch chairs with her. Oh.
She's not speaking.
No, she's going to speak after me though. But this is what maternal mortality looks in my house. The remains of Demi and Malachi together. Together. So it's real. I don't know if any of you guys have one of these of your child, but this is what I see every day. So this is why I fight. My name is Tracy, and I live in Bakersfield, and I'm a volunteer with Consumer Watchdog. And I'm a founder of Save a Mom, Save a Family Foundation. I have been advocating on behalf of my daughter and my grandson, Malachi, and for all the Californians. I want you to understand that I lost my daughter, Demi, and my grandson on that tragic day. My daughter, Demi, was 1 month short of getting her college degree at Cal State Bakersfield. She was a strong, educated Latina, and she was proud to be one. She was proud to be a Latina. She was excited to have her baby. She wanted her own little family. We need change here for all mothers. I am calling on this board to conduct a report on maternal health mortality. We are asking you to report on the numbers of complaints and received on maternal health, maternal mortality. We want to know how many complaints are received and how many complaints are closed and how many are received from repeat offenders. Oh, gosh. We need you to understand that all women of color are dying here in the Central Valley and across the state. Please don't ignore the 50% of our birthing population. And this was preventable. This was absolutely preventable. She should be here. She had the right. There was no reason for preeclampsia turning into eclampsia by a doctor, a repeat offender who ignored her symptoms, ignored her value. Was it because of her color of her skin? Was it because she was on Medi-Cal? He told her she was swollen because she ate Mexican food. That's what he said. That racial comment like that, which made her feel like she did something wrong. And this board had let him practice for years without doing anything. And I will continue holding it against this board that you didn't stop this sooner. You had every opportunity. You've seen his past. You've seen what he did. And yet you still let him walk away from retirement and health reasons and gave him 30 days to get his practice in order. Is that right? Is that what you would want for your daughter and your grandson? It's got to stop, because you will have another mother. You will have another mother sitting here saying the same story unless you guys make changes. And protocol, there is a protocol at the hospital that she went to. Did they follow it? Absolutely not. No nurse, no doctor followed the protocol for preeclampsia. Now, who's accountable for that? Who's checking the doctors to see if they're following the protocol? Nobody. Absolutely nobody. So every day, I sit with my daughter in this urn with Malachi and flowers that she asked to keep her spirit alive. And I will continue to fight. Thank you. And she would like to speak. This is Demi's best friend.
Hello, everyone. My name is Jade. My friend Demi Dominguez and her son Malachi both died to medical negligence while she was pregnant. Her concerns were not heard, and even though the doctor she had been seeing had many complaints and a record of medical negligence, and she had no clue. She wasn't given the opportunity to know what kind of doctor she was seeing. Had Demi known or had those previous complaints been taken more seriously, my friend wouldn't have gone to that doctor, and she might still be here today with her child who would be 4 years old. As patients, we have the right to know more about our doctors so that we can choose what's best for us. We know the ratings on everything else, so why not our doctors? We also deserve to know that our complaints and concerns are being addressed properly. Now, anytime that someone is pregnant, I am concerned with their well-being. I also have to stress to them to over-advocate for themselves, to make themselves heard, to hopefully prevent negligence, harm, and death. I also want to point out today that the public comments that are heard today are only the tip of the iceberg. There are many that have to work during this time or that can't speak for other reasons. Not everyone is able to have a voice, so I plead with you all to take into consideration that even if our voices seem small, we speak on behalf of others that are unheard or unseen too. My friend was not the first or the last person to die or to be harmed due to maternal medical negligence, but even one is too many and enough is enough. Thank you.
Thank you both for being here. I did just want to remind public commenters today, because I did it yesterday but didn't do it this morning, that we'd appreciate if you please not discuss the specifics of pending disciplinary actions, and that's because we want to protect the integrity of those disciplinary actions. So please do feel free to share your stories, but we have a concern that we don't want to jeopardize the integrity of those investigations as they proceed. So I know there are some of you in the room where there's a investigation pending.
Hi, my name is Michael Mack, and April Valentine was my first cousin. This is April here, 31 years old, was having her first baby, never got a chance to hold her baby because the doctor who she trusted for 8 months went and got on her boat the day of the delivery. And so my cousin was in labor for about 20-something hours while the doctor was enjoying herself on her boat, knowing that she had a patient at the hospital in agony, crying out for hours while being neglected. She never got a chance to hold her baby. This was totally preventable. And God has entrusted you guys to see that justice or investigation is done properly. All we are asking is that you do your job to the utmost. We're not asking for favoritism. We're just asking for justice and proper investigation where there's no lies, no manipulation, no anything that can jeopardize the truth. That's all we want. Her mother, thank God that the baby made it. My little cousin Anaya made it. Barely made it. If it wasn't for her father, she wouldn't have made it. But this was totally 100% preventable. And so the whole idea and the point in which we're here is we're pleading with you guys to please do your job. Dr. Gwen Allen has a reputation in our community. And we thought that my cousin thought because she was black, she was going to take care of her. But what we realized, it's not about race. Just because you're black, just because you're skin folks don't mean you kin folks. A black doctor failed her. Because why? She lost compassion and empathy. And she's able to get away with things such as this. So she's living her life, and she still got paid for a cesarean and all the other things, but we are left without our cousin, without our family. And we're just asking you guys to please do your job, because this 31-year-old beautiful girl is no longer here with us. I'm in therapy. My family's in therapy. And this could have been prevented. And we just lost another relative, 31 years old, bled to death because the doctor failed to stitch her up properly. So she bled internal bleeding. She was left, her husband is now left with 5 children under the age of 6, 31 years old. This is only 2 to 3 months apart. This is not a coincidence. This is an epidemic. And if we keep allowing doctors to get away with this stuff, many people will die and the blood will be on your hands. Thank you.
Thank you for your public comment. Are there additional commenters in the room?
I'm Nigel Robinson. April was my girl. I'm Nigel Robinson. April was my girl. And what I witnessed in that hospital from the nurses and the doctors, I'll never forget. If we pay the nurses and the doctors to take care of our loved ones or to be with them, to have the baby, why they're not doing it? It's crazy because I was left to do CPR while a nurse stood right there and watched. I did CPR 4 or 5 minutes, the nurse watched. The nurse put a mask on her and didn't even turn the machine on. But these are people we pay and the people we trust our life in their hands. She screamed and cried. We cried hours about her legs swelling. You could see it, red, swelling knots. They gave her medicine. As soon as they gave her medicine, she was out cold, started throwing up. They said that was normal. That's part of her pregnancy. That happened was epidural. That's normal. The nurses and them stood there. They watched as her blood pressure went from 180 to 220. Nobody never called a doctor. We cried and begged for help. And it's crazy that this many families here today because doctors failed them. Like we're in the world too. We supposed to populate. How can we populate and doctors killing us? It's not us kill. If I was to harm somebody right now, kill somebody, take a life, I wouldn't even be able to sit in front of y'all and talk. I'm going to jail. I'm not getting no fine. I'm not getting probation. They taking my life. I'm going down. But for me to sit there and watch all these nurses sit there and watch her die and leave me to do CPR for her to die in my hand and watch them slice her open and tell me my baby not gonna make it, that's like, should nobody have to go through that? So now I have to sleep at night raising my little girl, but also every time I look at my little girl, I gotta look at like images of her mama taking her last breath, because the doctor's supposed to not left that in my hand for me to have to try to save her life while she sat there and watched. So I say y'all should really look into a lot of these hospitals and these doctors, because they get paid a lot of money to do what they do. And now it's like we paying them to kill us off. So like I say, shouldn't none of us be here today? It's just, it makes me angry. So I'm like, it's all right, it's okay. I just feel like y'all should really do something, look into the doctors, the hospital, because it can't keep going on. Because like I said, if I was to hurt somebody, I'd be deemed to death.
Thanks for being here. Next commenter.
Y'all gonna excuse me, that's important, I gotta pick it up. Good afternoon. My name is Charles Johnson. I'm the husband of Kira Dixon Johnson. Before I say anything, I just have to pay tremendous respect to every single family that has stood before you and shared their pain, their experience. To Tracy, to Denise, to Xavier, I want to thank you all for the work that you all have done tirelessly every single day to make sure that this board showed up here today in Kern County. For those of y'all who may not be familiar with me, my wife Kira and I walked into Cedars-Sinai Hospital on April 12th of 2016 for what we expected to be the happiest day of our lives, and we walked straight into a nightmare. Kira was allowed to bleed internally for more than 10 hours while myself and my family begged and pleaded for them to take action. As you've heard from several people who've called in, we trusted Kira's life and her well-being and the life of my son to Dr. Naim. This board found Dr. Naim grossly negligent for my wife's death, as well as the near-miss deaths of multiple women, several of whom took place within a 3-month time span of my wife's death. I'm going to be very transparent with you all this afternoon. I had well thought out remarks of things that I wanted to say. And then a gentleman called in this afternoon and he said something that literally knocked the breath out of my chest. And what he said was, Dr. Naim was only given 4 years probation. This had never occurred to me. That Dr. Naim took my wife's life, took the most amazing mother in the world away from my sons. Yet his probation has come and gone, and I'm still here. I'm still here fighting and pleading with this board to get it right, to make sure that every citizen in this state has the safe, dignified care that they deserve. And I'm going to keep it real because I'm going to be honest with you all. I resent the fact that these families have to go through this. I resent the fact that they have to march up here and they have to pour their hearts out in front of you and beg and plead. You all have a responsibility. What is taking place in California is not only shameful here, but it's shameful across the country. This is a breach of public confidence. How many more families are we going to have to march into this room? How many more mothers are going to miss the first day of kindergarten? How many more fathers like Nigel are going to have to sit up there crying children to sleep because they just want their mother? And how many mothers won't be allowed to dance at weddings and grow old and be grandmothers like Demi? But what I want to make clear beyond anything is that myself and every single other person that is here are committed to, no matter how long it takes, we will be here until this board decides to do what's right. Thank you for your time.
Thank you for your comment and for being here. Next speaker, please.
Good morning, members of the board, media, advocates. My name is Denise Johnson. I'm from Tracy, and I'm a volunteer with the Consumer Watchdog. I came in this morning hoping to listen and learn. I learned much more than I thought I was going to. I thank these women for all the hard work that they did on this data. They collected an awful lot of information. I also thank Denise Pines for including the Native American women. I, too, am Native American. In addition, I am a patient of a rare disease. So I've been associated with the medical profession my entire life, 70 years. I've been with general practitioners, endocrinologists, nephrologists, geneticists, you name them, I've seen them, good and bad. And one of the things I've noticed is we have identified the issues here. And I think instead of trying to come midstream, maybe education, I understand we want to get doctors licensed quickly. I get that. We have a shortage. I understand that. But the people that are sitting behind me, they're in pain. Serious pain. Pain that's never going to go away, myself included. I think education at the bottom level, showing and educating our young doctors that these are our risk areas, and maybe perhaps spend extra time educating in those areas so that when doctors do come on board, they're already aware we need quality medical care. Quality. That's why you have these people. Our quality has gone down. Please reconsider the licensing issues. Again, I truly do understand, sir. We want our doctors licensed quickly so we can get them out there. I get it. But your caseload's going to get triple if you don't give us quality medicine. Thank you.
Thank you. Other commenters in the room?
Good morning. My name is Naomi Sweat, and I'm one of the many forgotten moms in the Central Valley, or in this case, forgotten sister. This is Sabrina Della Rosa, and I'm here representing for her and thousands of Latina families that can't be here today. I need you to know that My little sister Sabrina De La Rosa's life and death mattered. She went to the hospital twice that day. The first time she was sent back home, being told that she wasn't ready to deliver the baby. Her pain intensified and she knew something was wrong, so she went back to the hospital. She was given medication for pain, but her doctor never came to her bedside to see what was causing the pain. She collapsed coming out of the restroom. She lay there for 15 minutes before staff came to her aid. At some point, they took the baby by C-section right there in the room. My sister died, but her baby lived. He never was held by his mother. No mother should ever die this way. We are calling on the board to conduct a study, a report on maternal mortality and maternal negligence in California. We are asking you to report the number of complaints you received based on maternal health, the number of complaints that seek discipline and the type of discipline, and how those physicians that have received multiple complaints. This will be a stepping stone for future actions. Thank you.
Thank you. Additional public comment in the room? Oh,
I'm
go
gonna share
ahead.
real
Sorry.
quick.
Thank you.
I don't have anything written down. My name is Monica De La Rosa. I am Sabrina De La Rosa's mom. So you heard what my daughter said about Sabrina and what happened to her. But the aftermath of that is that she has 4 children. She left 4 children. She was taken from 4 children. The oldest one is just turned 17. She's a cutter and she's suicidal because she doesn't have her mom. Her little daughter's 11 and she says, "Nani, how come my mom died? She was so young. I thought you only die when you're old." Out of the mouth of babes. Her other son is 10, and he's a straight-A student, and he tries not to be seen because if you don't see him, you won't see his pain. Her baby Jack, after not having oxygen for 20 minutes, is a resilient little boy who will never know his mother's touch, who will never feel his mother's touch. We are a family trying to pick up the pieces of a daughter, sister, Annie, that was taken from us from a preventable death. All these things were really nice, what they were saying, but if we don't have adequate people that are following through with these things that we're supposed to do, it doesn't serve as a purpose. You can have all the head knowledge you want, but if you don't put it to work, it's not going to do any good. The nurse, when she first came into the room, the first thing she told Sabrina was, "You know what? Ankles together, knees drop." And me and Sabrina looked at each other like, what is that? Like, we were just like puzzled until I did it in my head and I said, "Oh, she wants to check your uterus." So like I had to do some stuff in my head to figure out what the nurse, who we trust so much, wanted to do. That's just a little portion of the episode that happened that night. It was horrifying. It was horrific. Something cannot be unengraved in my head. Her death is very public. It is very public on the medical board and on the hospital's incident reports. So if you want to read about what happened to Sabrina, you'd be very surprised and outraged by what happened. Thank you for listening.
Thank you for being here.
Good morning, everyone. This is such a heartbreaking type of subject, and we all know first do no harm should come into play. But something, we have got to stop dealing on the level of nepotism and favoritism when it comes down to people in this industry, because it is an industry. It's not just a profession. And one doctor will have children that are doctors, et cetera, and, you know, all the friendships. And sometimes the nepotism and favoritism gets in the way of the good old common sense. And when we look at the Hippocratic Oath, we have to realize that too often it is seemingly to have been taken by a bunch of hypocrites. And there is a parity between these words. And we also need to look at the industry to find out how much is being done to educate regarding prenatal health through physical exercise. For instance, I'm 17, I only had one child, but in the meantime, it was like spitting. Why? Because I was taking 6 dance classes, African dance, ballet, tap, and all that while I was pregnant. But how many doctors encourage their patients to actually get into physical activity so that will also make the baby more active, and along with that, that helps the baby to come out more on its own instead of so much pushing. Now, in the meantime, we also need to understand that doctors have been doing weird things to people for years. Even back when I was young, they were filling people up and doing ugly things to you during examinations. I screamed one day in the hospital, and all the nurses ran in to see why I was screaming, because the doctor was so perverted that he had come in with his small child, toddler, and then he was the foot doctor from a foot surgery was trying to do things in my vaginal area. That is weird. Okay, now, the point I'm trying to get to, though, is that with the salary basis that everyone has that's within the board, it's decent salaries. If the problem is, which we mentioned yesterday, that 30 people need to be brought onto staff, well, I'm saying get busy. As my cousin Pinky would say, get your work did. Get your work done. Get some people on staff so that people don't go away. They come in, and after 5 years, they're saying we've never received a response to our complaint, because there's not enough people working. And also create a portion of your staff to also do fundraising. It can be done. If it's done in the arts, it can be done everywhere else. And I've written grants for all colleges and arts organizations. I know people can raise money. And so we need to, if you need more money for things to be done, let's raise the funding, but also let's hire the staff so that people's complaints can be handled. But whatever you do, quit it with the favoritism with the doctors. I'm sorry if I seem abrasive. It just hurts so bad it almost makes me shake when I think about me having to scream in a hospital to get a doctor off me. So let's understand, everybody that goes to school to become a doctor is not a good guy or a good lady. So let's just go on and take care of the business of evaluating these cases and come up with answers. May God be with all of us, and I thank you for coming here for this. God bless you.
Thank you for your public comment. Next commenter, please.
Hello. My name is Kimberly Turbin, and I'm a volunteer at Consumer Watchdog. I tell my story a lot. It's about a doctor who had a reputation of being really mean to his patients, and the whole hospital knew. And, when I went to go ask why he was like this towards me, and I showed them my birth video, because I caught mine on video, they said, yeah, well, that's kind of like how he is. I said, okay. So I'm going to continue. I suffered disrespect while giving birth in a hospital in Los Angeles by the staff. And then it was followed with obstetric violence by the OB. who grabbed scissors and slashed my vagina 12 times. He said, if you don't like it, go have the baby on the floor or go have it in Kentucky. And then he proceeded to mutilate my genitals. This is the first time that I share this part of what the medical staff did to humiliate me while having a baby, before my son was even born. So because this assault isn't just me telling a story or notes in a chart, this really did happen. I have the whole entire thing caught on video. I'm just gonna play an audio of what I was told while giving birth in California. Did you guys hear that? Well, I don't know how to play it any louder.
Okay, now. 5 de Mayo, baby. Yeah.
They said that I was having a 5 de Mayo baby and he was gonna come out with a sombrero on his head. I just think that's like one of the most disrespectful things, and I don't really bring it up too often because I try to focus on like obstetric violence and why I was hurt to begin with, and why did the whole hospital know that this doctor practices that way. But then along with that, the staff is making fun of me. I don't know, it's because I'm Mexican or what they were trying to say with that. But to continue, I honestly believe that we need studies on what's happening with obstetric violence, and we need them also for the maternal mortality, because they both really go hand in hand. I found all the families behind me, we find each other online. Well, I've been telling my story for about almost 11 years now, and then what I discovered was mothers and babies that were dying. So that's why I'm here today. To continue, current data doesn't even show really our unique struggle as Latinas in public health and health systems, because I don't think our demographic data is accurate, because a lot of times we aren't identified correctly to begin with. We are calling on the board to conduct a study, a report on maternal mortality and maternal negligence here in California. We are asking you to report on the numbers of complaints you receive based on maternal health, the number of complaints that seek discipline, the type of discipline, and how those physicians have received multiple complaints. This will be a stepping stone for future actions. Thank you.
Thank you. Additional commenters?
Hello again. My name is Alka Airy, and I'm also a volunteer with Consumer Watchdog. I spoke to you yesterday about losing my older sister. An anesthesia error destroyed her lungs in 2014, and she later succumbed to her injuries because she was denied a lung transplant in 2018. And throughout those years, we both felt incredibly alone. We didn't think medical negligence happens to other people in a place like California, especially in a city like San Francisco, where we thought we had some of the topmost care in the country. But after my sister's death, I started meeting and connecting with other injured patients and their families. And I was struck by the numbers, but I was also struck by the many in Kern County. And I drove down from San Francisco because I wanted to see what was happening here. And it isn't just grief that binds these families here together. It's a doctor. The trauma, the injury, the death, the common denominator is a doctor. And I think we have to say to ourselves, there is something wrong here. We can't let the repeat offenders get away with it. And I want to thank the board for having this forum here today on maternal health, and I found the presentations incredibly informative and detailed. but they were lacking in the details around medical negligence and that impact toward maternal and infant mortality. And I agree with the other advocates here. I think we need more data. And there are only 3 places where we can get the data. We can look at court records to see lawsuits involving maternal infant mortality and injury. The malpractice insurance carriers are sitting on a trove of data. And if they were service inclined, they might make some of that information available so that we can truly understand the extent of maternal and infant mortality. But the medical board is also sitting on a trove of data. And it would be incredibly helpful to see, of the 10,000 complaints that come through the medical board each year, what percentage are related to maternal and infant mortality. How many are occurring in other parts of California, like Kern County? Are there concentrations in the inland areas versus the coastal areas? We have to look at this data and ask these questions before we can actually do something about it. And I think the medical board is in a very unique position to offer that data, not just to the medical community to see how the medical community can improve care, but to the communities here as well, to give them some assurance that the medical board is doing their job. Thank you.
Thank you for your public comment. Additional speakers?
Hi, my name is Anita. Bear with me, please. I've never done this. It's very emotional for me. I have 5 children. This is one of my kids, Trinity. Out of those 5 children, 2 of those pregnancies and births, I experienced something nobody should experience. I was a young mother. I was pregnant. I went to the doctor, choosing a doctor that I expected to take care of me and I trusted to have the best care with for my child, even though I was a young mother. I did not see that doctor for the few months of appointments. I didn't see him until I was closer to having my child. And the very first appointment I had with him, he automatically started saying remarks while he was supposed to be checking and examining me. Sorry. Examining my cervix to see how I was doing, if I was dilating or anything. He made remarks such as, of course, I'm a young mother, I'm Mexican. That's what we do. We have a lot of kids, no matter how old we are. As he was examining me, he did things that he should not do. But I was young, and I had no idea how to even make a complaint, who to even go to. I was 17, yes. That should still not have happened. I thought I picked a better doctor. The next time, the next pregnancy, I chose a doctor. Very well spoken of. Everybody had highest remarks of him. I trusted him. He said he would be there, make sure everything was okay. The delivery would be fine. He would be there every step of the way. I did not know that there was another doctor that worked in the office, never met this doctor, and that doctor would be the one to be at the hospital, so he decided not to go. I had no idea. I'd never met this doctor, didn't know their background. Didn't know their mannerisms, didn't know how anything would go with them. She also made remarks about how young I was. I've already had a child. She did not listen to anything that I said was going on. I had no epidural. My labor went so quick I had no time to even know what was going on. She treated me rudely, rolled her eyes many times, told me I needed to push and cooperate with her. She had stuff to do. She then ignored the nurses stating my son's heart rate was dropping, that they should probably do a C-section, that it was causing too much stress on the baby for her to keep me in labor. She dismissed their concern. She continued to try vacuum-assisted delivery without communicating what she was doing to me. All I felt was pain. I had no idea what was going on. She got frustrated and mad and said, "I'm not doing this. We're doing a C-section. Have her sign for it," and walked out the room. They explained what would happen on a C-section, as I had no idea what was going to happen. I was taken, prepped, and as I'm being prepped, she says she's going to do it on a local. I have no idea what a C-section on a local. I don't know what a C-section was. The nurse said, "The anesthesiologist is right here. He's going to be here any second. Can we just wait?" When she explained to me what it was, a local, "I will give you a couple of shots on your stomach and start the C-section. I don't have time." I pleaded to please wait. They said the anesthesiologist was right there. She didn't wait. She shook her head and started. I felt everything, the pokes, the incision, her tugging, everything. I was screaming so loud my family told me my child died. They could hear me down the hallway. That's how loud I was screaming. Nurses were stunned. They weren't even doing what they were supposed to be doing. Within seconds of them starting and to pull my baby out, the anesthesiologist got there, and the panic in his eyes, the horror in his eyes when he was trying to hurry up and put me under so that I was not screaming, not in pain. I thought that was it. I would never see my sons. I thought that that was going to be the last memory that I had. When I woke up in recovery, the doctor I chose that I trusted, that said he would be there through everything, he would make sure that it was fine, came in and repeatedly told me, "You know she saved your life. She saved your son's life. You know that, right? That's why she did what she did. You know that that's why she did. She saved your life. She saved your son's life." I had numerous nurses come in and apologize, crying to me that they have never heard or witnessed anything like that in their career. And I didn't understand at that time because of everything, all the trauma and everything going on. One of them told me, "You need to talk to someone. You really need to talk to someone about what happened." I didn't understand it, and I think it was her trying not to get in trouble to tell me to talk to somebody legally, that shouldn't have happened. And then it was horrific to find out that the doctor who I first saw, who made those statements of being Latina, so I was already not going to have the best care because that was in his mentality. He was the doctor that I found out was responsible for my kids losing their Aunt Demi and their cousin Malachi. I never heard that doctor's name because that wasn't the one she chose. That wasn't the one that she picked and saw through her pregnancy. 19 years later, after my experience with him, that still nothing happened to him. He still was seeing patients. I can't imagine how many patients got mistreated by him. Even without my complaint, when that happened with Demi, we seen how many complaints were against him, how many alleged everything, the lawsuits, everything came out. I could not believe that in that many years, he was still able to practice. No consequences for anything that he's ever done, even without my one complaint. There was many. I'm just asking, please, please don't let any other families go through this. Being personally experienced with it, having family that has had their lives taken away. It doesn't just affect them. My children live daily these past 4 years missing their aunt. She was so involved with them. She loved all her nieces and nephews. She was going to be an amazing mother. She didn't get that chance, and I'm just asking, please take that into consideration. These doctors need to be held accountable. They need to have consequences when they do something wrong. Investigations need to be very thorough. That's all I'm asking for. Thank you.
Thank you both for being here. Are there other commenters in the room? Come on up.
Good afternoon. I'm Michelle Montserrat Ramos, and I became a patient advocate 17 years ago, following the death of my husband-to-be, Lloyd Montserrat. He died at the hands of a substance-abusing physician. Thank you, Dr. Hawkins, for acknowledging the tragedies of all the people in the room. You and the board know how hard this team has worked to bring resources to a community that has been forgotten statewide. I now work for Consumer Watchdog. I work with families across the state of California. As I've told you before, I'd like to say that I didn't find Bakersfield, but Bakersfield found me. When I learned of a young mother's death here in Bakersfield, I reached out to her mom, who you've heard from, she's in the audience, to see how I could help. After a newspaper article and some media coverage, my phone began to ring, and it never stopped. Tracy Dominguez contacted me, then Xavier De Leon, then Celeste Ortiz's grandmother. It was like a domino effect. All these great families had one thing in common. They all had lost their daughters, grandchild, or son at the hands of a few doctors. This was just the beginning. I soon had tragic stories from families in the double digits. They were all Latino families. As this board knows, I formed a team of advocates. I like to refer to us as survivors. The local team here has done amazing work with me to bring much-needed resources to this community, which in large part has been forgotten. I am the voice for the voiceless. But we are working together to build our voice. I joined my team of advocates to call on the board to provide a report to the public on maternal mortality and maternal health. You've heard many of the things we would like included in the report. As I told Dr. Krause, a former board member, I was here before you, and I will be here long after you're gone. I am committed and dedicated to these families sitting behind me. I'm not going anywhere, neither are they. This is a crisis that impacts every single one of our families across the state of California. Let's start the movement today to save another mother and another baby. Thank you. Oh, also, I'd like to add that I believe she's on the line. Assemblymember Jasmeet Baines has been on the line. And she wanted to offer some comments. She's the assembly member from the Central Valley. She's on the phone line now, if you'd like to go, Chad.
Thank you, Michelle. All right, are there other commenters in the room? Can you all check on the phone line to see if she's there? Okay, is there a way to, and Michelle, I don't know if you're in contact with the assembly member, if you can ask her to queue up in the thing, and we'll take that comment, and then we We do have two more presentations, the local perspectives from Kern County that I'd like us to get to, and we will have another opportunity for public comment. But if the assembly member's on the line now, I'd like to take that if possible.
Good afternoon. My name is Kimberly Salas, and I'm the District Director for Assemblywoman Dr. Jasmeet Baines. In talking to your technical people, she was there about half an hour. Is that her? About half an hour ago,
okay.
To give comment. I am in contact with her to see if she's available after lunch, perhaps, so she can just call in and give her comments, if that would be okay.
That'd be great. We're not going to take a lunch break. We are going to take a 5-minute break here and then come back for the two presentations, the two local perspectives presentations. So she's welcome to, if she wants to come back in about 5 or 10 minutes, we can take her right at the beginning of those presentations. If not, we can take her during the public comment period.
I'll see if I can make a phone call to her and then find out, maybe get a good time.
Great.
For that.
So thank you. So why don't we take that 5-minute break now? And so we'll see you back here. It's 12:12. Let's see everybody back at 12:20 sharp so we can keep going. Thank you all. I'm going to call the meeting of the Medical Board of California back to order. Our next speakers are going to provide local perspectives from both Kern County and Los Angeles County. And I'm going to introduce all 4 of the upcoming speakers, and then we're going to start with just a couple of them. Brynn Carrigan has been the director of Kern County Public Health since January 2021 and has over 16 years of experience working for the County of Kern. She's a Kern County native, and her passion is to help improve the overall health and wellness of Kern County residents through public health services and through health and fitness initiatives. Kimberly Hernandez is the Division Director of Health Services at Kern County Public Health, where she manages and supports a variety of services, including, among several others, the Maternal, Child, and Adolescent Health Programs, California Children's Services, Communicable Disease, Vital Statistics, Public Health Clinic, and the Public Health Laboratory. I'd also like to introduce Dr. Melissa Franklin. Dr. Franklin is a public health leader with over 25 years of experience in organizational development and communications for both public health and public education. Dr. Franklin was appointed the Director of Maternal, Child, and Adolescent Health for the Los Angeles County Department of Public Health's Health Promotion Bureau in November 2022. In this capacity, she oversees programs that support the health and well-being of pregnant individuals, infants and children, including, among many others, the African American Infant and Maternal Mortality Prevention Initiative. I'm also pleased to introduce Adjoa Jones, who currently serves as the African American Infant and Maternal Mortality Outreach and Engagement Director, excuse me for the mouthful, at the Maternal, Child, and Adolescent Health Programs of the Health Promotion Bureau within the Los Angeles County Department of Public Health. She's the founding lead of the first AAIMM Community Action Team in LA County and the co-lead of the South LA South Bay AAIMM Community Action Team. Ms. Jones has worked within the Los Angeles County Department of Public Health and Department of Health Services for the past 26 years, serving in various programs to improve the health and wellness of women, men, children, and their families throughout the county. We are so grateful that you are here with us today. I would like to just check in and see if the assembly member was on the line, if we were supposed to check in with her first. It looks like maybe that's not the case. I don't see her representative in the room. Okay, so we'll come back to her during public comment, and then we'll begin with Ms. Carrigan and Ms. Hernandez. Thank you so much for being with us here in person today.
Good morning, or good afternoon, members of the board. Thank you so much for the opportunity to speak with you. I'm Kimberly Hernandez, and if we could bring up our slides. Do I need to play it? Okay. There we go. So we appreciate the opportunity to speak to you and to provide some local context about this conversation we're having about maternal and pregnancy-related mortality. So first up, a little bit about Kern County. These are some beautiful pictures that you can find throughout Kern County. It's a very beautiful county. We're a county of more than 900,000 people, and our county spans more than 8,000 square miles, and it can take 4 hours to get from one end of the county to the other. Our median household income is a little over $58,000, and that's in contrast to the California median income of well over $85,000. It's about a 30% difference that we see here in Kern County. Over 76% of Kern County residents have earned their high school diploma or the equivalent, and this is compared to the state average of 84%. Even sharper is this contrast in bachelor's degree. Over 18% of Kern County residents have received their bachelor's degree compared to 36% of California residents. And so we know that there are many hardships right off the bat that we face here in Kern County. As Dr. Ramstrom has described earlier, Kern has one of the higher rates of pregnancy-related mortality in the state of California. It's about 13% higher than state average. When we look at the southern Central Valley region, you can see that after a decline in the early 2010s, there's been a small increase in pregnancy-related mortality over the past few years, and this is part of the reason we are all talking about this today. We see a very similar trend here in Kern County, though these are 5-year averages instead of the 3-year averages that they use for the region. However, when we take a look at Kern County's trend line compared to the state, you can see that this gap has narrowed. Between 2009 and 2013, the pregnancy-related mortality rate in Kern County was about 82% higher than the average across California. And between 2016 and 2020, which is the most recent data we have available, that difference is now down to 13%. So it's important to note that, as we have mentioned multiple times today, the rate across California is increasing, and we have also seen here in Kern County of recent years that decline we've been working so hard to continue has also turned and is on its way up. We are hopeful that with continuing and renewed efforts, we can turn this trend around here locally and throughout the state and nation. We want to take this opportunity to talk about some of our perinatal health programs that we offer at Public Health. The first one, which Dr. Ramstrom also alluded to, is our Black Infant Health Program. And while we call it Black Infant Health, we all know that the foundation of infant health lies in maternal health. As you heard earlier, the rate of pregnancy-related mortality among Black women is 3 times higher than other racial and ethnic groups. BIH is a program dedicated to empowering Black and African American women through culturally appropriate education and services to improve Black infant and maternal health. We enroll Black and African American women who are pregnant up to 6 months postpartum, and so women can enroll even after they give birth, because we know there are areas where help is needed, even if they didn't need that earlier on. There are no income requirements or restrictions, and it's designed in 2 modules, which includes individual case management, where staff come to your home, and group sessions. The group sessions are really designed to build community among the program participants, and many of them remain friends long after they graduate from our program. BIH takes a team approach. We have family health advocates who teach educational components, group facilitators who help strengthen that social support, public health nurses who provide clinical assessments and answer medical questions, and mental and behavioral health professionals who support moms through the ups and downs of pregnancies and new babies. We've got an image of here some of our amazing staff in our BIH program. Another one of our programs is the Nurse Family Partnership Program. This is part of the California Home Visiting Program initiative that Dr. Ramstrom mentioned. And this is a national program that works with first-time moms, first-time low-income moms, and their families to support healthy pregnancy, early childhood development, and economic self-sufficiency. These public health nurses and their support staff serve families through early pregnancy through the time the child turns 2 years of age. The nurses meet one-on-one with clients in their home to provide them with a health education, medical assessments, and social supports. As you can imagine, they develop very strong bonds with these moms and their families because they get to spend close to 3 years with them. While NFP currently does have a waiting list at our public health department, we are always accepting new referrals, and we are currently increasing staffing to be able to serve more families in this program. Last year, our Nurse Family Partnership Program served nearly 200 families. Almost a quarter of the moms were under the age of 18. Obviously, as a program for first-time moms, we enroll a lot of young people. But we do put a special emphasis on prioritizing moms who are under 18, as we know that they are at higher risk of adverse medical conditions and socioeconomic outcomes. 84% of our mothers in the NFP program identify as Hispanic, and 15% were Spanish-speaking. So it remains important for us to have Spanish-speaking staff to serve these families. 43% of the mothers in the program were also either working part-time or full-time while they received services in our program. And a third of the mothers who were over the age of 18 when they started the program but didn't have their high school diploma or their equivalency when they began the program actually completed their equivalency exam by the time they graduated from the program. The last 2 points speak a lot about how hardworking our clients are. And you can imagine how proud our staff are as we support them through making the best lives that they can for themselves and their babies. Another one of our programs is our perinatal outreach program, which we affectionately call POP. It serves pregnant women through 1 year of age of the infant. This program has no eligibility requirements and seeks to reach clients early in their pregnancy. Staff meet with clients in their homes to provide education and support and nutrition, around support and nutrition, reducing or eliminating harmful substances, following doctors' instructions, and much more. They help eligible patients enroll in Medi-Cal and WIC and connect patients to other resources like transportation services. After the baby is born, they provide support around breastfeeding, newborn assessments, infant care, and early childhood development. Last year, 86% of our POP clients identified as Hispanic, and 41% were Spanish-speaking. For this reason, it's been especially important for the majority of our staff who work in POP to also speak Spanish. One of the important services that our staff are able to provide is to accompany clients to their doctor's visits to help advocate for the client and to remove any communication barriers that might exist because of the language barrier. Like our other programs, staff become really invested in their patients. And now I'll turn it over to our director, Brynn, to talk to you about one of our most recent initiatives.
Good afternoon, everybody. As Kim stated, my name is Brynn Carrigan. I'm the director for Kern County Public Health. Thank you so much for having us here this afternoon to address your board on some programs and services that we provide here locally in Kern County. It takes a village is a common theme that I've heard throughout this meeting among comments made by board members and by people that have been presenting. And BEMHI, or Black Infant and Maternal Health Initiative, is Kern County's village attempting to address the factors that we can influence from multiple angles and perspectives. We really try to humanize the data and the statistics by ensuring that there are a number of seats within the initiative that are filled by real women with local lived experience with pregnancy and childbirth here in Kern County that are this affected demographic, that are Black women. 16 of these seats are represented by governmental agencies, healthcare providers, hospitals, managed care plans, community-based organizations, faith-based organizations, and schools. We have a very diverse group of people trying to address Black infant and maternal disparities. We spent an entire year as an initiative developing a 3-year strategic plan. We wanted to make sure that we were addressing some of the true issues that our local community feels like are leading to some of these poor outcomes that we're seeing in our African American population. Part of the result of that 3-year strategic planning is that we have 3 main goals. The first of those main goals is career paths. As you may be aware, we do not have a medical school here in Kern County. We have 10 acute care hospitals, and a majority of our healthcare providers are not from Kern County. Many of them are not from California, and many of them are not familiar with some of the issues that we face here, the challenges that Ms. Hernandez spoke about earlier, our demographics, and specifically our maternal health outcomes. So we want to make those career paths available here locally, and we're working to do so. The second is really addressing and destigmatizing mental health, and that was a very strong topic that was brought by many members of this BEM-HI committee as something that needs to be addressed specifically in our African American community. And the third is healthcare provider education. As I mentioned earlier, most of our healthcare providers are not from the area and are not familiar with what our health outcomes look like here. We see it with many of our diseases, just like we see it with our maternal health outcomes. So we're really proud that in the first year we were able to hold a healthcare provider symposium where we were able to provide what those stats look like and have real lived experience from some of our African American doctors that are operating here locally. And I was surprised to see how many faces were surprised at the data. And that tells me that we are not talking about this enough. And so as part of this initiative, we were successful this past month in getting $200,000 to go towards a public awareness campaign. This is going to help us not only educate our local healthcare providers, but also educate our local community about what these outcomes look like so that they know exactly what it looks like here in Kern County. And I know it was mentioned earlier about every time we address one demographic group, we're addressing all demographic groups to some extent. And I find that very true because every time we have the conversation about what our African American maternal and infant outcomes look like, we are comparing them to other demographic groups. And so we're having this much larger discussion while our focus is African American with all of our other demographic groups that are disproportionately impacted. And so at least the conversation is started, and at least we're talking about what that looks like here in Kern County. And with that, I think that concludes our comments, and so we'll remain available for any questions.
Thank you so much. Are there any questions of our board members? From our board members, excuse me. Dr. Hawkins.
Well, thanks for coming in. It sounds like you have a number of programs that would be needed. Just curious, and this is a general question, you can decide how to answer it. How do you measure success? I realize that you mentioned at least 4 programs, and how are you doing with that success?
Yeah, that is a very difficult question to answer, Dr. Hawkins, because when we're going to see a difference in our maternal health outcomes is going to be years in the future. And so we want to be able to measure some successes earlier than that. We have set very, we call them SMART objectives, but objectives for every goal that we have to meet with a timeline associated with it, with a number of healthcare professionals that we have to interact with and educate, a number of doctors' offices that we have to go in and not just educate the physician, but educate the entire office staff about what this problem looks like. And so we have those timelines to measure our success, we have those numbers of touches to measure our success, and then hopefully long-term we'll see the decrease in those maternal health outcomes.
Thank you very much. And I imagine that public awareness campaign you're going to have will reach out to all Kern County mothers, families, right?
That's absolutely going to be our intent.
Thank you. Mr. Watkins.
Yes, thank you for the presentation. I just had a quick question. What do you think whether the fact that most of the population that in this region is Hispanic or Spanish speaking, and then you say all these health providers are coming from outside of here. And that cultural difference, how much do you think contributes to the outcomes that we are seeing here?
So I don't think I could give you a number, which is hard for me. I'm an epidemiologist, so I love to give numbers. But we do know this has an impact. We hear this from our clients, where there is both a culture and often a language barrier. And sometimes with these programs, the best thing we can do is help them understand instructions that these clients were given so that they can be compliant. Because on the flip side, we have this. When our staff who are familiar, with our community and familiar with our healthcare system can help bridge that gap to help, a provider understand this patient isn't non-compliant, they do not understand. And if we can explain it in a way that is culturally sensitive, that they can understand and they're happy to comply because they want to trust in their healthcare provider. And so we know this is a big gap we see in our community. We have a wonderful nursing program here in Kern County, and so we have been able to see lots of local people. Brynn and I are both natives of Kern County, and so watching our local community grow in itself to, again, reach out and support itself is wonderful. But as Ms. Carrigan mentioned, the lack of a medical school in Kern County in the Central Valley really impacts where our physicians come from. We hope to continue to grow them, send them out to medical school, and that they want to come back to work in the Central Valley in Kern County, but we remain a significantly impacted healthcare provider shortage area. And so we know this is a big both cultural and language barrier that we continue to seek to improve on. But any help that this board could provide in encouraging that would be really amazing.
Wow. I feel like I'm having the same conversation that I just had last night. Because, when you speak to the doctors, a lot of the interactions with patients is somewhat nuanced. And they kept mentioning it in the previous presentation, it's nuanced. And if you have such a big gap, there's a way that we communicate just by our presence that is that then is non-existent. So you could easily misinterpret so many critical signs. I wasn't planning to make that discovery today, so thank you.
Dr. Balot?
Thank you for your presentation, and I was really, it's a challenge to run 4 programs at once, all at the same aim, and then getting your measures of success, but I have confidence that you'll pull it off, right? But my question has to do with your kind of what we'll call PFACs, or patient, family, and advisory councils, because those are the voice of the people, right? The mothers, the fathers, the tias, and everybody else, right? So the question is, do you have something set up so that families can have a voice during this, so that it's important? And do you have, besides your community health workers, do you support doulas, or that whole process? So 2 questions there.
I'll start. And that is such a big component of our BIM High effort. We are trying to establish what we call sister circles, and it's not just that spousal support, but it's a community support. So you really kind of engage in these larger groups of people that will support you through whatever it is that you're going through. And we try to really take that same approach in our BIH program at Kern County Public Health, where we are really kind of trying to get people grouped together that are experiencing the same thing, so they can help each other, lift each other up, teach each other how to advocate for themselves, and that sort of thing. So we're really trying to work towards that. And then I apologize, but I forgot the second part of your question.
You're really lucky, so did I. It was good, but but thank you. I think I was talking about the patient family, and you talked about the advisory council, and you explained that. And I think then I guess the follow-up was the doulas and
Yes.
the community health workers.
Yes, and we actually have a doula that's sitting on our BEM High steering committee and is really trying to promote how we can incorporate doulas more into this prenatal care and the birthing process and how we get more acceptance in the hospitals for doulas to be in the room. And so she brings that lived experience as a doula to the table, and then we work with the other healthcare providers that are on the steering committee to discuss how we gain that acceptance and how we get the word out and how do we even raise people up as doulas, because there isn't a lot of doulas here in Kern County.
Dr. Hawkins, you have a follow-up, I think?
Bless you.
Question regarding medical providers. So you don't have a medical school, and I don't know if that's something that's in the works, but you have nursing schools. Are they able to, do you have any mid-level nurse practitioner programs here?
Not locally.
No.
Not locally. A lot of, we do have a number that do online school and then do rotations for their clinical practice. And so, we are grateful for that ability for people to learn sort of remotely and then go out and do clinicals, in our community. And so that has been helpful, but we do not have those mid-levels where they can come and learn in our community that way.
Dr. Tsai?
I have a technical question. I'm very impressed with all these programs. In terms of support and funding, is this all a public venture, or is this public and private, meaning the hospitals, the insurance companies, do they participate, or is this solely a public, state, or county-funded endeavor?
So BIH and NFP are both state funded, and so those are two programs that Dr. Ramstrom mentioned that CDPH supports, and so they don't cover all of the costs. The county picks up the rest of it. POP is county funded and partially funded through other maternal and child health funding, and so it's not specific to POP, but that's where we spend that money in order, because we saw the gap in still a large need of many mothers and families that could use this support. But also, particularly with the language barriers that we found, that POP really helps fill that, and having culturally appropriate and in the patient's primary language that supports. So we don't have any private ventures that fund this, the programs as a whole. So,
additional questions or comments? Okay, we're going to move on. I think, thank you, Ms. Carrigan and Ms. Hernandez. We are going to move on to the second part of this presentation with Dr. Melissa Franklin and Adjoa Jones. Welcome. Thank you for being here.
Thank you for having us. Thank you for having us. Oh, yes, thank you. Thank you, esteemed medical board members, for the honor of sharing with you today, and to the Kern County community members, and to our collaborators for justice for mamas and for birthing people across California, Denise Pines, Karen Ramstrom earlier today, and Dr. Gregory, a consumer watchdog, and I'm excited to see the work of Kern County Health Department related to its Black Infant and Maternal Health Initiative. I'm honored to be joined by my dear sister friend and colleague in the work, Adjoa Jones, and finally to those who have experienced a loss of a wife, mother, partner, friend, or baby, or loss of the healthful and joyous birth experience they wish they could have had. To this injustice, I promise you, we are leaning into change and not letting go. I am Melissa Franklin, Director of Maternal, Child, and Adolescent Health for the LA County Department of Public Health and the Bureau of Health Promotion, and one of the founders, along with Adjoa, of the Los Angeles County African American Infant and Maternal Mortality Prevention Initiative, whose work you will hear about today. The programs in the Maternal, Child, and Adolescent Health Division include the African American Infant and Maternal Mortality Initiative, which we call AAIMM, the AAIMM Doula Program, AAIMM Fatherhood Program. We also have a Black Infant Health Program, Help Me Grow, which is our developmental screenings and support, Medi-Cal enrollment, a doula program that's budding for Medi-Cal covered doulas, and a host of other programs and services for youth, children, and families. I am also a Black woman with a college degree who had a traumatic, life-threatening birth experience. Both of my children, born approximately 3 years apart, were born 3 months premature. Yet, I acknowledge that I'm one of the fortunate ones, as though my husband and I endured great struggle and heartache with the birth and aftermath of their births, which raising preemies is no joke. In the first 2 years, you're just trying to keep them from dying, but I guess that's parenthood too. In some ways, to this day, we survive, but that's not everyone's story. Right, survival, and it's also not the point. Survival is the bare minimum standard of maternal care quality, and health, well-being, joy, abundance should be the ultimate standard, and that really drives our work in the county. Next slide. Oh yeah, thank you, sorry. Okay, thank you. So for our discussion today, we'll talk a bit about the Los Angeles County birth, justice, and injustice context, what the data tells us, the LA County AAIMM prevention initiative, some of the structural elements and the programmatic elements, and then we'll talk about what does it look like looking ahead for our initiative, some lessons learned, and final thoughts with the invitation to connect with us. Before I go on, I want to share a summary from a recent C2C maternal morbidity and mortality weekly report. Maternal deaths increased in the United States during 2018 to 2021 with documented racial disparities. Respectful maternity care, for example, preventing mistreatment, communicating effectively, and providing care equitably, can be integrated into strategies that aim to improve quality of care and reduce pregnancy-related deaths. But what's learned that's new is approximately, not a new experience, but new in terms of research, approximately 1 in 5 mothers overall and approximately 30% of Black, Hispanic, and multiracial mothers reported mistreatment, for example, violations of physical privacy or verbal abuse. During maternity care, approximately 40% of Black, Hispanic, and multiracial mothers reported discrimination during maternity care, and 45% of all mothers reported holding back from asking questions or discussing concerns with their provider. Next slide. Today's presentation is about the power and passion of lived experience to activate truly enduring transformative change. It's about the power of the village, which we've been hearing today. I want to note that we're talking about differences, about inequity and disparity. This does not disregard that we as a division are working for joyous and beautiful, abundant births for all mamas. The discussion today will share about the differences between the outcomes. And as this slide represents, infant mortality rate by mother's race and ethnicity, shared with you, I'll call it chunks and 3-year averages in LA County from 2004 to 2021. It's important to note that in LA County in 2021, there were 95,897 live births in our county. Of those, 7,500 were Black babies. Starting with infant mortality, because though our focus here today is maternal mortality, in order to paint the picture of the disparity that is pounding Black communities in LA County, and how egregious it is, and not lessened by the less frequent nature of maternal mortality. As Dr. Gregory, I believe, said today, you have to save the mother in order to save the baby. Infant mortality, as you know, is measured by every 1,000 births. As you see here, though infant mortality overall has decreased in our county, the disparity remains, and it's sat pretty much at 2 to 3 times the rate over the past several years, larger in earlier years. And I know it's really small. The orange line represents African American births, and again, African American infants. The blue line, white, yellow Hispanic, green Asian Pacific Islander. I wanted to note that Native is not included here, but consistently across our state and nation, you will find that Native communities experience disparately higher rates of infant maternal mortality as well. Next slide. So though the 3-year average gives us a more, this is the duplicate in a lot of ways. You can go to the next one. I have a more current one than this. Thank you. LA County in some ways is separated either by supervisorial districts, of course, but also service planning areas. We have a pretty diversity in terms of geography, also weather pattern, as we found recently. And this really shows the disparity by service planning areas. Antelope Valley has the highest infant mortality rate in our county. And then South LA, South Bay, which Adjoa is the founder of the community action team there, are neighboring areas, and together they share a high mortality rate. And they're the regions in our county where you do have higher concentrations of Black individuals living there. Next slide. Okay, here we go. So infant mortality rate, when we look at it by year picture, we do see an improvement between 2020 and 2021. This is not a time for us to rest on our laurels or even say that we've done it. As we know, years fluctuate, which is why we measure in 3-year averages. But still the disparity remains. Next slide. Now to maternal mortality. Again, maternal mortality in our state, as you know, has decreased over time, and now we're seeing increases across our nation. In LA County, it's markedly greater than any other ethnicity in our county, and definitely far from the Healthy People 2020 goal. In fact, in LA County, Black mothers die at 3 to 4 times the rate of any other race due to complications from pregnancy and childbirth. Next slide. When we look at it in terms of 5-year averages in our county, each of these bars represent different years. The African American Black maternal mortality rate in LA is shown in the set of bars that are second from the right. And you see it far exceeds any other racial and ethnic group in our county. And even though that rate has decreased, the difference is what we're talking about today. The difference has remained. Next slide. So we're looking at, well, why is that? You know, we've been talking a lot about that today. And so we, in addition to talking to Black mothers, birthing people, and their families, right, the folks with a lived experience, we explored reasons for the disparity, in some ways developing a null hypothesis. Let's look at some of the things that people typically think are the reasons why someone experiences a premature birth, death of an infant, or maternal mortality. So we looked at health risk behavior, right? So this is preterm births by mother's race, spice, and smoking status, comparing mothers who are Black and mothers who are white. On the right-hand side, the 2 bars are Black non-smoking or never exposed to smoke, and Black individuals who smoked. And of course, yes, healthful behaviors are good for pregnancy and childbirth, right? Not smoking is good for pregnancy and childbirth, but is not the reason for the difference. On the right-hand side, if you look at Black individuals, mothers birthing folks who never smoked, had no exposure to smoking, and you compare it to white women who smoked, it's not much of a difference, right, in the outcome. So again, Black non-smoking versus white smoking. So comparing the 2 middle bars is not much of a difference. So that gives us a clue that it's not exactly that Black folks are smoking at greater rates, and that is the reason for the disparity. Next slide. We looked at proxies for socioeconomic status and access to health care, right, which in this case is education. And so on the far right, the orange is African American, so I can be clear. The blue represents white mothers, and we're looking at preterm births, right, so birth outcomes. So on the right-hand side, that orange bar is a preterm birth rate for Black women who have a master's or more, right, a graduate education. And on the left, white women who have less than high school education. And the rates are almost commensurate. And when you compare, again, on the right, Black women who have a graduate degree with the second set of bars from the left, white women who had a high school diploma, you see that we have, again, commensurate, right? So it tells us it's not education status, it's not social status. You know, as I mentioned, you know, when I had my both preemies, I had a master's degree, a stable relationship, a home, a job, a healthy weight, danced exercised during my pregnancy, folic acid, and yet I had that outcome. So in LA County, the situation is complicated when we talk about the reasons why, the root cause. Definitely racism as a root cause and the pounding of our history of racial oppression and injustice on Black folks' bodies, presenting itself in greater vulnerability, plus implicit and overt bias by our systems of care and our systems of health. System failure are other systems not showing up as they should for Black families, education, criminal justice, family court system, economic discrimination, which is experienced at greater rates in LA County than any other group. And so that pounding compounds, right? So oftentimes we focus on one thing, mistreatment in a healthcare setting, which is definitely a problem, or racism as a root cause, which is definitely a problem. It really is an interaction of these things resulting in a birth that is markedly different than our colleagues of other races. That's my youngest, Heaven, on the right. She's thriving, alive, and well today, thanks to just the support of my village and home visitation program that was transformative in my life. And so like many in our movement, we live this work, right? And that is the power of lived experience, right? Of bringing those things together and understanding the why as a root cause and that the data has lives behind it. Next slide. So with that, I'll turn it over to my colleague, Adjoa Jones, who's been really out in the front lines of our response to this crisis as we built this work.
Thank you, Dr. Franklin, and thank you to this Medical Board of California. You heard my bio, but I come with about 31 years of experience in this work. While in college, I was approached by a nurse. Her name was Delilah Crenshaw, who I absolutely adore, who saw me working as a student in the immunization program and saw the need for me to join the work. So I was the first community health worker and perinatal health educator for the first Black infant health program in LA County, which was Great Beginnings for Black Babies and I worked under the Inglewood Healthy Mothers and Baby program. And so I have seen this work for a mighty long time. I've worked with organizations like Black Women for Wellness, where I learned a lot of policy and advocacy for women and girls of color in our county and across the state. And so I've seen the need of what needed to happen differently from not just the analytical side, but from the practical side, actually being out in the field, learning policy, learning engagement, and really working with others. I also was a former teen mom. I'm now a grandmother of 2, and so I'm very familiar with what is happening to and in my community. And so what for me it is that we are more than our data. I had seen this data in my county not move the needle like we should have for a very long time, meaning that we did not even get to a halfway point of reducing infant mortality. So in my role previously with the Department of Health Services with Whole Person Care, I was able to come up with a vision and idea for forming a community action team that didn't just focus on African American infant mortality, but really focused on maternal mortality as we were seeing the rise across our nation in moms dying. Also, I saw the need that, in this nation, we started recording the Black-white infant mortality gap in 1850, and looking at your banner, you started in 1876, which means that if we've been recording that long, we have not really figured out how to fix the problem. And I saw a way for community and government to come together to look at a way to fix the problem. For those with the lived experience, for those grassroots organizations and advocates that have been doing the work, but maybe not getting the finances and resources to really expand, to come together and look at how we as a department and how we as a community could build a public-private partnership to reduce the incidence of death and disease in our community, especially with moms and infants. Next slide. So the AAIMM community, as you see and you've heard today, many have talked about it takes a village. And so when we first started some of this work, Dr. Franklin was then a fellow at First 5 LA before she came into this position as the first Black MCH director in LA County, which we're very proud of her. that we came together, and she worked this comms through her consulting firm to create this communications for us to talk about it takes a village to create a joyous and celebratory and healthy birth. And that was really what we wanted to focus on. So the AIMM, and that's our acronym, is a coalition of the LA County Department of Public Health, also health services and mental health, and First 5 LA, combined with our community organizations, mental and health care providers, funders, and community residents. And our overarching goal is to eliminate the disparity in Black birth inequity, eliminate the disparity of deaths and as well as morbidity for Black families, and not just Black families, because as we discussed here, if it starts with us, then it will also be fixed for others. Next slide. So our AIMM values exist, and we focused on when we came together, and I will say and talk a little bit more when we get to the community action team, is that we're focused on racism as the root cause. Black women had to be upfront and leading. Our Black folks as well. We brought Black men into this work, and so we'll discuss some of that as well. Fostering equity while fighting inequity, and looking at this as racism and implicit bias, because Dr. Ferrer was one of the first that I experienced in public health to really raise the issue that racism was one of the leading causes of infant mortality. Also, pieces of the puzzle. Everyone has a role, so there's no big I's, little U's. There's just everyone coming together. This involves clinicians. This involves doulas, grandmothers, fathers. We looked at having a lot of our faith-based organizations there. We had even grandmothers wanting to be doulas from the Win 1000 Grandmothers Pray organization. So we brought everybody that I at least came and brought everybody that I knew over those 20 plus years, and then others brought others that they knew. So then also my experience in starting in this work, it was a lot of victim blaming and shaming that we did in the 90s, because we were coming out of a drug epidemic and we're back in a drug epidemic. And so it was a lot of focus on what women weren't doing. And sometimes we hear that still today, what women aren't doing. But if we combine our efforts, those that are clinicians and those that are paraprofessionals, along with the individuals that we're serving, then we can focus not so much on blame, but how we can fix whatever health issues exist and how we can lessen the burden on our healthcare system. And so that's what we've been really focused on in this group. Next slide. So what is our AIMM program framework? So before we really got started in building and creating the AIMM Prevention Initiative, LA County had created the Center for Public Health for Health Equity, and they were focused on a 5-year equity plan, an action plan. And so as the action plan was formed with the various departments that I mentioned, mental health, health services, and public health, we looked at ways in which we could be a part of the strategy. And they're listed here. Strategy 1, reducing women's exposure to stresses in the social environment, blocking the pathway from social stress to physiological stress, intervening as early as possible if and when stress has taken a toll on their health, and creating the infrastructure needed to achieve 1 through 3. And here's what happened a lot of times when we presented this. Folks would, and I've heard clinicians even say, well, if they just reduce their stress. And so we've also heard others talk about the weathering impact. And when you talk about racism and its impact, especially on Black folks, we're talking about undoing 400 years of oppression. And when this racism starts even pre-birth and in the womb, and then early on when our children enter elementary school. Next slide. So what are our actions? We have, and you'll get to see more about some of the actions, but what we've done in looking at addressing racism and discrimination that had driven this disparity, the AIMM community has come together, and we created Dr. Franklin along with First 5 and Public Health, and Helen O'Connor created a steering committee. And the steering committee is basically those at like the C-suite level. Those have founded organizations in our community. Also those leading organizations that are serving Black mothers and folks and their families. And then from the community action team model, the purpose of that and why I had the vision for that, again, I shared, was to bring public and community together and for everyone to participate. So if you're at the community action team, it's not just sitting on a board or sitting in a meeting. We're actually doing work and creating interventions and strategies to reduce the impact of disease and death, and also look at how we can create safe birthing spaces. The AIMM Village Fund was created along with public health, and one of our great advocates and what I want to call a fund development agent. She's a social change agent, Casey Patterson. And in that Village Fund, along with some of the members of the steering committee, is to allow for us to provide individuals as well as organizations. So you don't have to have a specific 501c3, but you can be a member in the community that wants to serve, and you will be able to get funded up to $30,000. And so we're on our third cohort and about to enter into the fourth very soon. And so these individuals end up serving their community, whether they're providing yoga, they might be providing some dance, they might be providing classes, social support, and things of that nature. And so this has been a great success because they're also being trained and provided with organizational capacity and infrastructure through those programs. We also wanted to reduce the threat to health, public awareness campaigns. Dr. Franklin was very instrumental and had worked hard to create these public awareness campaigns and created our Black Infants and Families website, which we wanted to be separate of any organization so that we could be able to share without a lot of bureaucracy. And so we're able to share the resources of other organizations that are partnering with us in the work. We also got involved and had in addressing social determinants of health, some trainings around earned income tax credit and paid family leave, because a lot of folks do not realize how much money they're leaving on the table and how that also can benefit when it comes to some financial constraints that folks often have. Then we wanted to improve health, so we have our AIMM Community Doula program, where as Whole Person Care was one of the first funders of our AIMM Doula program. And that is a program that, and I'll talk a little bit more about, where we had 10 doulas, African-American doulas, that were serving African-American women and birthing folks at no cost to them, free in our county, and that started in 2019. We also participated as a community in our Antelope Valley and South LA community action teams participated in the application process for the Perinatal Equity Initiative. And out of that, we were able to get funded for group prenatal care and fatherhood support. And then finally, some of that we've also addressed is being a part of the Cherished Futures for Black Moms and Babies Hospital Collaborative, of which I'm one of the community advisors for a hospital and had been for a previous one. So we're in our second cohort. And then Charles Drew University is one of our providers of the group prenatal care, and they came in initially with us when we first started AIMM, and then developed the CDU, Black Maternal Health Center of Excellence, where we have 2 maternity homes in our wellness centers in our county, one in South LA and one in Antelope Valley. So we're super excited about that. And then we have the clinical prevention of preterm birth, and lastly, pregnancy intent screening and preconception health promotion, of which we have partnered with Essential Health Access to provide those trainings to our community. Next slide. So this is our AIMM infrastructure. We used to talk about this and say that this was like our flower. It's now gone to a garden and then soon be its own nursery, because we are continually expanding. And I didn't share at the beginning, we started this, and when I started, there was no funding. There were just people that were interested. Our first introductory meeting for the community action team really launched this work. We had over 100 participants. I got Kaiser to partner with us and provide us with the space, and we had to turn people away just to find out if folks were interested in a community action team that would really address this issue in our community. Our approach is a collaborative of collaborative shared decision-making, community engagement, I started with one community action team. Now we have 4 throughout the county, and there's still others that want to expand, and we have to tell them, hold on, because capacity is just real. You know, we don't have enough, but we are looking to see which ways we can do that, because if you saw on the slides previously, it doesn't have to do with where you live or how much money you make. Wherever our folks move and Black folks live and reside, whether they're impoverished or wealthy, this is happening to them. Next slide. So this is just one of the flyers and an example of our community action team. What happened with, even with COVID, we did not let COVID, when it started in 2020, impact our community action team. I came up with the idea because in our community, you always have these little words or things that come up, urban slang or information or something that people are talking about. And at the time, people were talking about what's the T. And so I said, since we're going to have to be virtual and we can't be in person, we created the virtuality. And the virtuality happens every month, and it's kind of like an informative session where we may have dads speaking about their experience. We have same-sex couples sharing. We've had pelvic floor 101. We've had what is a doula. And so in mental health, how postpartum anxiety disorders really impact, and what are the needs of the family. So we've been doing that since early 2020, really March of 2020. Next slide. Some of our activities of the community action team is we meet bi-monthly, and it's open to all. So anyone in our community can attend those meetings. We have monthly work groups. Each CAT has a structure of where there's a planning team, and then that planning team is also supported by a backbone support agency, of which we've been funded previously by foundations, and now we've had First Five to fund us. They're funding us for the second year for our 2 latest community action teams that were formed, and they help support in these monthly work group meetings that we have at least 2 to 4 work groups in every community action team. Out of one of our first community action team was formed Black Daddy Dialogues, which in sharing before, bringing Black fathers into this conversation so that they could be very aware of the risk associated for their mothers and their future infants. We wanted them to be able to have conversation and really dialogue and support. And so this was created by one of our gentlemen, the Henry Solomon, and he created it to be for fathers of Black children. So you don't have to be a Black father, but you have to be fathering Black children. We also have supported Black Maternal Health Week, which was formed by Black Mamas Matter Alliance. And as soon as they formed that, we've been providing Black Maternal Health Week events, including community resource fairs and baby showers since 2018. We brought Black Breastfeeding Week to our county in 2020. That was created by Kimberly Seals-Allairs. And we've just had in June our second annual Father's Day Juneteenth Resource Fair and Baby Shower, which we were able to support, pay special attention to the late Bridget Cromer and to Nija and April Valentine's family. And we also have, I talked about the community virtualities, special awareness campaigns, outreach and media campaigns, and collaborative partnerships with a number of our organizations. As you can see on that flyer, those are just a few of our partnering organizations. Next slide. This is some of the pictures from the baby showers that we've hosted, as well as our Black Breastfeeding Week. And as you can see, our team, I created a shirt that says Support, Protect, Believe Black Women with our website on it. That has been going over all over the nation because folks are very interested in how they can get involved, and they know that there's a strong need to support Black women in birthing and pregnancy. Next slide. So the AAIMM Doula program, as I shared, is a community doula program. The first piloted program was held by HealthNet, and that ended up being led by Frontline Doulas and is still serving our community today. And then we came in through Department of Public Health to create an AAIMM Community Doula program. And the goal is we have evidence that shows the efficacy of doulas in reducing preterm births and one of the leading causes of prevention of infant mortality. And so we've been able, through this doula program, to bring folks in our community, that some of which started in the Community Action Team, one, to lead that work in building that program, along with Helen O'Connor, and then to further look at ways to best serve our community. And we are very proud of the work that we have done in that community doula program. There's wraparound support, client-centered support, infant care and safety. I will say that myself and 3 other colleagues were able to participate in a policy with the Beatrice Solis Women's Policy Institute and bring the first doula board motion to LA County, which our supervisors approved in January of 2020. We further supported SB 464, which our current supervisor Mitchell wrote with Black Women for Wellness when she was a senator, as well as we've supported SB 65, which now allows for doula care for women who are receiving Medi-Cal, for all women to receive that. And so that was part of our work at that doula board motion, because we knew that we wouldn't just serve Black women, but we would serve all and ensure that they had the services that they needed. Next slide. Client eligibility: Black birthing in LA County, 18 or older, or foster youth, no insurance, income, or gestational age required. And for folks to learn more, they can just visit our website. But many times we're out in the community. We have our doulas at several events sharing of the work that we're doing. And that's just a little bit about how to refer. Next slide. Current status: we're fully staffed. There's a need to expand, but we're looking at as the approval of the last motion brought before the board, we have a doula expansion that's going to look at additional training to be provided to our community members. Frontline Doulas has been one of the leading folks to provide training for those who want to be Medi-Cal approved. And so we're looking at what that will also do for our community, because we know there's not enough doulas in California to serve all of the women that would like, are interested in, and need to be served. We also have our Care First and Community Investment Grant Support Special Prison Program. So we're in one of the women's jails in LA County, serving women who are interested in the doula and are incarcerated at the time. And we're also training community members to become doulas to serve in the jail system and program. We have, this is some late numbers, so it's been updated. We have over 880 referrals, 300 current clients. 500. See, I told you it needs to be updated. Over 400 births, and our outcomes have been increased breastfeeding, reduced C-sections, increased connections to mental health services, and so much more. Next slide. To talk about our fatherhood and program, we have an Expectant Fathers group, and this is for new fathers. They go through a 5-week session with our fatherhood program coordinator, Davion Malden, and it is really empower fathers to really be able to get active in learning to be new parents, also looking at ways to be advocates for their infants as well as their partners, and really become members of our work in the Community Action Team as well, and help other men to come into this work. So we're super excited about what we're doing in our county and how this is helping to serve our community. But like I shared previously, we're more than our data. And we need to look at that this has been going on far too long, and we cannot just simply focus on data. We have to focus on individuals and serving them as humans and as we would like to be served as well. Next slide.
So wrapping things up in terms of what's up next for AIMM, it really is being able to sustain funding for our work. The Perinatal Equity Initiative out of the state of California has been instrumental in launching a number of the programs that Adjoa explained. We're also looking at opportunities for third-party payment with AAIMM, enhanced case management, reimbursement, the fact that Medi-Cal now covers doulas. sustainable infrastructure, focusing on, we're refining our steering committee and a structure in order to ensure that we're engaging in greater power sharing, and that folks are leading the work are individuals with lived experience, and that we as public health, that we step back and we listen, learn, and then lead. Continuous building community, membership, engagement, partnerships, deepening our clinical care quality efforts. We have an outstanding partnership with the Association of Black Women Physicians. We've hosted several, or co-hosted several town halls with them and for their provider networks, which includes providers who are not African American. We recently held a doctors and doulas and Mama's Oh My, which was really transformative. We talked about some of bridging the relationships between the provider community or the obstetric community, gynecological community, and doulas, and we're going to be doing a couple more of those in the near future. And then social determinants of health focus, we're really looking at housing in terms of those that are unhoused in LA County. Black individuals are impacted among the worst. And then a guaranteed income pilot that we'll be launching in the fall. That income pilot is part of a 5-county collaborative with a partner, Expecting Justice. It will provide stipends in an amount of $807 a month to individuals who fall into one of 5 categories, including Black birthing folks, individuals who've had a prior preterm birth, individuals with who are pregnant, who have sickle cell anemia, prior heart issues, and a history of high blood pressure. Next slide. So lessons to be learned, and I think Adjoa had noted it before. 400 years of harm cannot be reversed in just 4 years of intentional effort. And the contexts need to be addressed as well, which is where the social determinants of health come in, which is where deepening provider relationships come in. Solidarity is vital for sustainability and for seeds of impact. Multicultural solidarity. LA County is not one race or ethnicity, and neither is the AAIMM initiative. The community action teams have individuals from all walks of life, all neighborhoods, socioeconomic status, races, and ethnicities, and we are united with that singular purpose of addressing the injustice. Multi-sectoral, there's not one sector within our county that shouldn't be a part of care apart this work, and multidisciplinary. Another lesson learned is an intense and sustained focus on those most harmed is the only way that we will see impact for those most harmed. Like general strategies are great, but they get us to a certain point, right? We have to focus in on the community that's experiencing the greatest harm and really understand and focus there. And then again, an intense and sustained focus on those most harm actually benefits everyone. If we can improve clinical care quality or how Black folks are treated, everyone else will benefit. And actually a great example of that is the Medi-Cal doula benefit. And a lot of the structure of that legislation, the billing rate, the fact that it exists really came out of the heightened awareness of the disparity experienced by Black folks. It came out of the Black Doula Network in LA County and across the state, and other doulas who really raised their voices for change, and now it's a benefit that is available to all individuals who participate in Medi-Cal who are interested in receiving the support of a doula. And actually in LA County, we're looking at how can we support that even further, increase our doula workforce, all doula workforce, improve how doulas can access onboarding to the system, which is kind of clunky and complex. And we as a health department are currently in that process as well, and we can attest to it being clunky and complex. So how can we make that more streamlined? And then clinical quality and surviving birth, as I mentioned in the beginning, is a bare minimum. Abundance, life, joy, and long-term well-being is the penultimate outcome, and that's what we see as being what our success is. And then asking why before asking how both require wisdom from lived experience and acting on it.
Thank you, Dr. Franklin. And as I close up, this slide I created, it's been about 4 years ago. Well, no, really in 2020, because that is when in the upper left, my side, Amber Rose Isaac passed during the pandemic after sharing that she was going to share her experience at the hospital where she was in New York. And then I saw on social media where LaShondra Hazard in the middle, beautiful young lady in her 20s, was sharing that, hey, I'm at this clinic, I'm experiencing pain in my belly, and nobody is responding, and they're telling me that nothing is wrong. And by the end of that night, her and her unborn fetus had expired. And then you all met and know Charles Johnson, and the story of him and Kira was really what really pushed many of us out back in. We were thinking about this in 2015 or so, or really, what do we need to do? What are we going to do? And then this young lady in her early 20s, Catherine Terry in Antelope Valley, died early in the pandemic while attempting to give birth to her son, no health risk. And my bottom line here is there is no acceptable rate of maternal mortality. As Stacey Abrams, the esteemed Stacey Abrams, shares, maternal mortality rate shows that mothers, especially Black mothers, risk death to give birth. And that should not be our case. And that's why we really wanted to push out this work, because what is happening when we don't acknowledge what is going on and we don't really push for a fix, then we're creating families that are torn apart. We're creating more dysfunction in our communities. We're also increasing the workload for our mental health providers, because all of these families will need mental health support and resources and care, because you never get over the loss of a loved one. I did not lose my sister due to a maternal death, but I lost my sister and I watched her bleed out for 24 hours at a facility in LA County, and nobody did anything to fix that. We didn't, my family didn't push for that to bring it to you all. My stepmother didn't. I really wish she would have. But these are the things that we experience as a community that has to stop. And we cannot ignore what goes on as if it is something wrong with the people that are entrusting their care to physicians, because it doesn't mean that we don't think highly of physicians. It doesn't mean that we're not going to think less of them. We're going to go to them for the care like we would anyone else, because that is the model that has been presented. And so we don't want to leave that out, but we do want to look at what should be done. We want to expand the midwifery model. We want to expand doula care, build rapport and relationships, and we do that to build rapport and relationships between physicians and clinicians. As Dr. Franklin shared, we have the Association of Black Women's Physicians that has been a partner with us since the beginning, because they're really interested in making some changes. And so we're excited about just that. But we have to share this, the facts and the historical truths if we want to fix a problem. Otherwise, we can just sit here and say we really don't want to put a fix on this. We're just going to continue to pour more funds and time into something, and we're not going to really make any difference. And as others have shared, and I don't want to speak for all of those families, but we really work hard with our families and did not know that I would have to add more people to that picture that slide before. That is not my interest at all. But how can you get involved, and how can folks get involved? They can join our listserv by reaching out to me. Celebrate, encourage, and advocate for the well-being of Black women. Whenever I see a woman that's pregnant, I generally will run over to them and ask them, do you have a doula? Do you have a supportive system? Would you like to get involved in our work? Because it's really important to me. I didn't really want to, it's some things you don't really particularly want to do, but this is not a work that we're here for making a lot of money. We're actually here to improve health outcomes in our community and see that folks are able to thrive and survive. You can also follow us. We have 3 social media pages, Facebook, Instagram, and Twitter, and we have our Black Infants and Families website. And attend a meeting. We have folks that, you mentioned one of the physicians, I can't see your name, I think it's Dr. Hawkins, mentioned about students. I actually have plenty of medical students that some have said I'm their mentor, and I don't even see how, from UCLA that are in. One is in her last year and will be joining us at the Black Birth Equity Summit next week. And she has come out to a number of our events. We've had our Kaiser doctors participating in these walks for justice, and they're very interested. We've had nursing communities come to our CAT meetings so that they can learn too. So it is imperative that we do start at the medical school as well. And then finally, this is how you can stay in touch with myself, Dr. Franklin, and Helen O'Connor, who are the primary leads for our LA County AIMM Prevention Initiative. So thank you for your time, and I appreciate everything that is being done and for allowing all of us in this room to come before you and share.
Ms. Jones and Dr. Franklin, thank you so much for that presentation and for being here with us in person. Are there any questions or comments from our board members? Dr. Hawkins?
Yeah, just briefly, so again, thank you very much for your early recognition of the needs that were warranted for infant and maternal health. I do have a question about, are you totally dependent on California statistics, or are you developing your own statistics about how you're doing with the programs that you have?
We have, we're fortunate enough to have in-house evaluators. I mean, we do draw from the California Department of Public Health's various data sources, vital statistics, their dashboard, which is greatly improved and is a great resource. And then we have an evaluator, a consultant client, who is actually just did a long dive into our initiative, interviewing a bunch of folks, looking at our data. And so each of the program areas have their own evaluation. For example, the doula program, each year they're submitting an IRB to be able to track outcomes, experience outcomes, as well as birth outcomes, some of which we cannot report yet because the numbers in terms of preserving anonymity is challenging, but we're constantly monitoring that. In terms of our communications campaign, we're looking at more than just like eyes seen. Are people engaging with it? Do they note that, do we see a change in the tenor of how folks are talking about the issue? For example, our focus initially was not to, we're going to be clear about there being an injustice, but we're not going to stop with the death and dying. We're going to talk about joy and abundance actually being possible for Black folks, and what steps do folks need to take in order to engage with them. The fatherhood, expecting fathers group, again, matter of fact, they just submitted their next IRB in order to track how dads experience it, what the birth outcomes are for their partners, whether or not there was an increase in self-efficacy and confidence as it relates to advocating for their mamas. So it's that. And then we're constantly tracking like year by year and updating on a quarterly basis birth outcomes through vital statistics. And we do our hand crunching because we have to organize them by service planning area. And the state doesn't do that for us. We do that.
Excellent. And where you can, you'll present data so it'll be available for the public.
Yes, through our Black Infants and Families website, and then we have an MCH dashboard or data center that's on the Department of Public Health's website, and then we're developing a dashboard for our AIMM initiatives as well.
We participated in some other work. There's going to be a report coming out from the state for centering Black mothers. We had a number of organizations that was led by Black Women for Wellness, and they work with UCFS and UCSF and some other folks to create that. And it's been a couple years coming, but because we didn't have the data we needed for Black moms for over 30 years, we pushed for that. And so we're looking to see more maternal mortality and morbidity data that we can support. And I was able to push Dr. Allen, who's our Health Promotion Bureau chief, to add maternal mortality to this work because the focus initially in LA County was just African American infant mortality. And so we wanted to make sure that we're not doing siloed work, that we're doing a strong community effort.
Thank you. I had Mr. Watkins and then Dr. Thorpe.
Yes, I just want to say thank you for bringing this. Hearing the actual causes was a little jarring, I must admit. When you just say, the reason why all of this is taking place is because of racism and implicit or overt bias, structural racism. I come from the country where we topple the system of racism. And I know that's like hitting a brick wall every time. And eventually the people resorted to other means, but that is not my question today. My question is, if I'm a Black woman today pregnant, how do I prevent this from happening to me? Because if I take all the things that you have said today from the previous experts as well, and I'm running into that wall, then I'm running into that wall, and I'm hoping for the best. And I'm not a hoping guy. I like a game plan that gets a result. So I'm curious. You've got 30 years in this. I've got 6 hours.
I'll say this, and Dr. Franklin, if you want to follow up. That was the point of doing this, to give folks hope, right? But we should be looking at beyond hope. If we just talked about hope, we wouldn't really bring up racism, because nobody wants to really talk about it. We have, sadly, governors that are telling us slavery was a good thing for black folks. I don't understand how people like that can even keep a job. It's up to us to really fix a political system that has been failing us, because folks like that shouldn't even be able to stay employed. Other people are being removed for what I feel like is a lesser crime. And so if you have folks, it's hard, like you said, because you have folks saying one thing, but you have other folks experiencing another. And so what we work to do was really educate and bring awareness. We worked to be able to speak it out loud, whereas there were times where you couldn't speak it, where folks would block you, and we're just really speaking our truths, and those truths are being heard by some folks that really got behind us and supported. We have foundation support. We have this entire department. We started out with just a community action team. Now it's a whole unit in MCAH. AIMM is a whole unit. That was not what I saw and envisioned would happen, but it was what I knew needed to happen, because I know that I wanted to have other mothers feel like they were able to be supported. Other dads feel like they were able to be supported. So we're creating tools for advocacy, and how to advocate for yourself, how to bring a doula or someone or a family member or relative into this work, and teaching them the empowerment that they have, that they can change providers if they choose to, that even if they're on Medi-Cal, you have a right to change provider. You have a right to report someone. You have a right to speak up and be heard. You have a right to acknowledge that this is my body, and this is not what you're experiencing on the outside of me is not what I'm experiencing on the inside here. So I need to figure out how to bridge the gap, to talk to providers, to look at, how they're coming across, and how we build this relationship between folks, and how one of the things I didn't show, because I do the historical piece generally when we're doing this type of presentation, and one of the things I learned through that piece, that it was an NPR study on black mothers dying, and it talked about preeclampsia and how this report and how preeclampsia was one of the leading causes of preventable maternal deaths, but also how black moms who suffered in a racist system or practice when they were going through birthing would not go and go for their checkup, their 4 to 6 weeks after, but they would still schedule a visit for their child to go see the pediatrician. So it doesn't mean they're not willing to be seen, but they just were not willing to continue to experience this traumatic issue of being unheard. So we have to build a system where they're advocating. And so much of I'll close with this, much of the folks that come into this work, they're either creating their own doula practices, they're going from being doulas to midwives, they're becoming lactation education specialists, they're starting nonprofit organizations, or supporting and getting into this work. So, and they're sharing the message that I can and will, and I do have a community of folks behind me to make sure that I don't die in the pregnancy and birthing journey. Did you want to say anything?
Thank you. I would also add, that's why we say there's a place for everyone, because it is an all system, all hands issue. I mean, number one of our strategies is end racism, which is like that's a long haul. Our other strategies are disrupt the pathway of physiological stress from the social stress of racism, address the harm to the body if that physiological pathway has taken hold, right? And one of the things that we heard that we've been hearing from black pregnant folks is, I'm pregnant, I'm scared to have a baby. I don't want to get pregnant. I want to have a baby, but I'm scared to do that, and that's not good. That's not good, right? And that's why we were saying about hope and abundance. And so if I was looking at my old pregnant self, I would have all the things. You know, I'd be thoughtful about my health pre-conception. I'd get a doula. I'd lean into how my provider treated me and who that person was. And if I didn't like it, I'd change it. And I didn't know that I could do that. I'd be in the Black Infant Health program. I really would, or a group prenatal program. I'd have a midwife. I'd have all the things. So these are all these are all advocates. These are all folks that are in my corner so that when I go into labor and the plan goes awry, that I'm centered, that I have some way of mitigating stress before I get into the delivery room. And then beyond that, our systems, our policies, access to quality care, redefining what we mean by quality, how we treat folks being that. What's the context that providers are working in? Overburdened, under-resourced, not enough staff. That's like a petri dish for bias and harm and choices that aren't positive. And so I would have all the things, right? And so that's how we approach our work. That's why we say it takes a village. It's beyond that. We have to be the village. And we are encouraging families, Black pregnant folks, to activate their village and receive support from the fellow village. And our call to action for providers, are you a part of the village too? Right? It looks a particular way. It behaves a particular way. You know, we're inviting our provider community, our physicians, to return to their first love. You know, our assumption is you got into this because you wanted to see health in abundance, and something has gone awry. You know, join with us to return to that first love and have that first love include Black folks, right?
Dr. Thorpe, you had a question or a comment?
Yeah, well, just wanted to follow up. I would first of all want to say thank you again. It's been like drinking from a fire hose today, but I'm a primary care doc. I'm an internal medicine doc, but I delivered a few babies in medical school, but I don't really have anything other than that, except for the birth of my own children, and which was a wonderful thing. But I hear what you're saying about the need for the support and that just hurts me as a physician. It just makes me so sad to hear that, because I don't doubt that that's true. I just am saying, I just don't. So I guess my question is, how are you engaging the clinician provider community, the physician community, and not just physicians, but nurse midwives and licensed midwives as well, in creating. Obviously, we want this marked disparity in Black maternal mortality to become. We don't, as everyone said, we don't want. I mean, any maternal death is not right, but we certainly want that disparity to be gone. So, one question is, how are you engaging the clinician community? Because I think you're right. I think getting back to, what most physicians went into medicine because they want to be helpful. Mm-hmm. That's what they really wanted to do. And you're right, there's a part of it where in the process, things, you got change, you got debt, you've got all these other problems, you're working too hard, you've had a marriage fail, you've got all these other issues going on, and your life starts to deteriorate. So, and it comes out in the way you act. I mean, those are the problems, and that's what we see at this level. Is we see those folks who are who are not having they're not having that healing relationship with their patient family, you know. So I just interested in, are you having any success in reaching out to the delivery community in the OBGYN family docs that are still delivering, and then also delivery rooms in the hospital? How is that working?
So we have a couple of things that have gone on. I shared, like, I can't say it enough, Kaiser has been a great partner in this work with us, because we started with some of our community program managers that then brought us to some of our physicians, and then some we knew in passing and work, and I mentioned Association of Black Women Physicians, because some of the Kaiser physicians were very much involved, and then you had several of those that were very interested in being a part of the work, some of which have sent their staff to become doulas. And so it's about building and educating. And so as Dr. Franklin shared, there was and right now we just had a meeting this past week with Association of Black Women's Physicians to look at how to have that communication and conversation between doulas and clinicians, and to build this community of birth workers, because they're all birth workers. If you talk about midwifery, there was recently, a few months back, Public Health is Midwifery Conference, and we had midwives come from across the nation that really have been doing this work for a number of years. Some that are just not certified midwives, but actually are midwives that have been trained in midwifery, and showing and sharing with us their model of work. We're also looking at policy development. So we have in one of our work groups, which is now a part of our overall AAIMM prevention initiative work group, is a policy and advocacy work group. So we're really going to build that work out. We're going to have a mother board, so that, as you asked Dr. Watkins, we'll have mothers that can come and be a part of that, to look at what policy and advocacy work should be created and developed, and so that we can also bring the clinicians into that conversation. We have had some of our clinicians have joined our community action team and are looking at ways in which they could do this work better. We've invited them. We've held 4 screenings of Denise Pine's film and Monique Matthews' film, Birthing Justice, around our county, to educate our entire community, including the physicians. And so, and the Cherished Futures for Black Babies, yes, is a hospital collaborative. Some, I won't talk about the successes or fails there, but we've really worked hard to have community members and advisors to work with the hospitals and looking at ways in where we can improve the care and improve the relationship. I just did on yesterday a community outreach and engagement lunch and learn with several of the hospitals who joined that lunch and learn. And so what we have to do is look at ways that we could communicate well with one another and get back to humanizing what is going on, and really doing an overhaul of our healthcare system. I mean, it has to be a huge fix. There were too many families that came up here to talk about their horrific experience, and nobody wants to be burying their child. It is not, that was not the way we were supposed to be created, to be burying children. And so we have to talk to physicians about that. We've lost some physicians. I saw during the pandemic a pediatrician who died, and she was a leading pediatrician while giving birth. That leaves that family structure really destroyed. I've worked a long time, even with Nigel and their family, and working with Charles and talking to these men. We have to bring these clinicians and these individuals who've suffered into conversation, so we can look at improving care. The mistakes happen. Let's be realistic. But we have to look at how do we fix the mistake, and how do we not do a cover-up for something that just creates a pattern of abuse and trauma. I hope I answered your question, Dr.
Yeah, so did you have a follow-up?
I would also add, in the meantime, establishing, going to points of accountability. So we're developing great relationships with managed care organizations, insurance providers, developing a system within our county where there is a more timely response to news of maternal death above and beyond the maternal mortality review process, which is, that takes, it's a different process. It takes a year and a half, right, before there are recommendations, and then the recommendations are generalized and redacted. So those are the in the meantime measures, and then also in the meantime, working with our Department of Health Services. So at minimum, our county hospitals and their clinicians are providing high quality care and are receptive to doulas and other birthing supports.
I'll find one last thing is also we've had the doctors do presentations. So like during COVID, some of those doctors did presentations for our virtuality. Some of them also yesterday shared, like, do a meet the doctors so that people can actually, you build this rapport with your community by sharing your work, teaching about AMA, against medical advice. What's good, what's bad, the pros and cons. We have to go through the whole spectrum and all the various health issues, whether it's hypertension, preeclampsia, obesity, any of those things that you're saying impacts the death, then we should have conversations about it within our community.
Sorry, just to follow up. So specifically, most physician deliveries are related to OBGYN physicians. And their local organization in Los Angeles, have you had any success or any interest in reaching out to that group of physicians to try to help obviously we want all these other people too, but it would be helpful if we could get help from the physician side and the hospital side as well, right? So if we didn't have to have these army of people to come get the job done, it would be helpful to have receptive people on the other end. So I'm just wondering if you've reached out to them.
We have. I believe that's the next frontier of our work. I mean, through our then comprehensive perinatal support program, which focuses on Medi-Cal participants. We have an entire unit that works with those OBs around their perinatal care quality, but beyond that, I would say not yet. So welcome and intro and a warm handshake to a group like that.
So Dr. Franklin and Ms. Jones, and frankly to all of the expert speakers we've had today, I just want to thank you again. I will say as a woman who's been pregnant 6 times, I have 3 wonderful, thriving kids. I also have the privilege of serving on this board. I knew this was going to be an impactful day. I don't think I had any sense of how impactful this day was actually going to be. I am feeling both devastated by the scope and breadth and depth of this crisis and this problem, but I'm also feeling at the same time so inspired by the work that's going on, by all of the experts, by all of the programs, by all of the advocates who've been here and who aren't able to be here. And I'm already looking ahead to how I'm going to reflect on this meeting and reflect on what role the Medical Board of California and frankly the data streams and the information we have can play in affecting these outcomes in a really positive way. So again, I'm just so grateful to have had the opportunity to be here in Kern County, to have learned from so many incredible people. It's, like I said, it's been both devastating and inspiring, and in my own mind, I'm trying to reconcile having those feelings at the same time. But thank you again. I do want for us to move on to public comment. I know that the Assemblywoman for this district, I believe, is on the line, so I'd like to go to her first. And again, thank you for being here.
Thank you.
So let's open it up for public comment from the Assemblywoman first, and then we'll go back to the room.
Thank you again, and thank you. What's your name, the doctor here? I don't see your sign.
No, I'm Rebecca Bond. I'm legal counsel to the board.
Oh, thank you. Thank you so much. Thank you, everyone. And want to thank our Senator Lola Smallwood Cuevas for inviting and adding us to this group.
Yes, thank you. All right, do we have the Assemblywoman on the line?
Hello?
Welcome, Assembly Member. We're pleased to hear from you. This is Christina Lawson. Please proceed.
Can you guys hear me?
We sure can.
Dr. Baines.
Yes, welcome. Your line's up.
Hi, thank you guys so much. I apologize for not being able to be there in person today. I am Dr. Jasmeet Baines. I am the elected Assembly Member over 8035, which comprises Kern County. I have been a family doc. I'm still a family doc. Have been on the front lines of a lot of prenatal care in the community. This is something that we've been advocating for a very, very long time, not just today. I remember even as a student seeing the cases of high maternal mortality happening across the country. In addition to neonatal mortality, prompted a lot of work from the American Academy of Family Physicians to advocate effectively in D.C. to get more research around what is happening across the country. And the number one thing that we saw a lot, specifically in Kern County, has a lot to do with the fact that a lot of the patients in Kern County are majority Medi-Cal. You don't have very much privatized healthcare insurance in Kern County. The majority is Medi-Cal. And the problem that it creates is a continuity of care that happens when a woman becomes pregnant and seeing the same OB-GYN. If there's an insurance switch, if there's an out-of-provider network, there's been a lot of issues making sure that that woman is able to see the same physician over and over. Not just that, Kern County is also an area that's very hard to recruit physicians to. So a lot of times there's physicians that will come in for a couple of months and then come out. There's a lot of rotating physicians, so that creates an additional barrier to the continuity of care. The other thing that happens is a lot of lack of access to health care. I worked out in Taft. I was creating the prenatal services out there for several years, and the biggest problem was a lot of women would show up in their last trimester seeking care and have never had any access to care prior to that. The other thing is there's a lot of complications in Kern County. Actually, the high-risk OB at Kern Medical has a huge panel. Not just that, we have a lot of other disparities that happen, valley fever. There's a lot of high-risk pregnancies that happen, especially in Kern County, because of a lot of access to health care. It's really hard to recruit physicians to be here. Personally, I grew up right here in Kern County. This is my home, and I have been here working on the front lines ever since. I'm super proud to be elected to the Assembly to bring this voice higher. It is a big, growing problem, and it's the maternal mortality in addition to the neonatal mortality. I oversee the Mommy House at Bakersfield Recovery Services, which is a residential-based treatment facility for women that are undergoing substance use treatment in addition to being pregnant at the same time. There's a lot of diverse programs that are needed specifically in Kern County to address this, and it needs to be a whole-around approach as well. As a physician, I have not gotten the support from a lot of people in the community to reach out and create collaborative efforts to bring eyes to this growing problem specifically in Kern County. I can attest to that. And as a family doc, I deliver babies. I have provided prenatal care, and there was no support system for me. At the end of the day, of seeing 100 patients a day and then, more patients on top of that, yes, there is a big problem of the fact that I didn't have access to health. The healthcare system, specifically in areas that are so underserved like Kern County, is falling apart. And that is where we need to have extra eyes, extra resources. And if there's any other place in the state that deserves these extra eyes and resources, it's Kern County. And that's something I have effectively advocated for many levels, not just in my community, but now as a state assembly person. Anybody that knows me in Sacramento knows how deeply and passionately I care about the problems that are happening in Kern County, and I continuously will advocate for them. And at the same time, there are physicians that have done wrong, and they need to be held to the highest accountability of the law. There are bad doctors, there are good doctors, but the bad doctors need to be held accountable so the good doctors can continue doing the work that they've been doing all along.
Thank you very much, Assemblymember Baines, for joining us. We really appreciate hearing from you. And like I mentioned, we're just grateful to have the opportunity to be here, have the medical board's quarterly meeting be here in Kern County. So thank you for taking the time out of your day to join us.
Yes, thank you so much for being there. Again, I apologize. I was not able to be there in person. I look forward to continuously working together to bring solutions to this problem. We need solutions, and we need them fast. And I would just advocate that we bring in an abundance of resources specifically for Kern County. So thank you so much for having me.
Yes, thank you. All right, are there other public commenters on the line? No. Okay, we will open the public comment period up. So if if people want to take the opportunity to join by phone, or is there anyone here in the room who'd like to comment at this time?
Took me 3 days to figure out I needed to sit down. I wanted to, first of all, thank you so much, because we visit churches often in the ministry, and I know people in this area, even though I grew up in other parts of the country and world. But in the meantime, I wanted to just make sure you knew I was thankful for this. And also, I wanted you to be aware that doulas are wonderful. And the fact that Medi-Cal is covering doulas is really great. A doula being in hospital with a mother is tantamount to a wealthy family hiring a nurse to be constantly in the hospital room. So just like wealthy people can do it because they have few extra nickels, but then there should be that type of care for other persons. And then along with that, the best thing that ever happened to me is my mother was a nurse and a special needs teacher. So when I was carrying my baby, it's almost like I was living with a doula because much of the time I was at my mom's house instead of, at home in my own home with my husband. Now, going on from that point, I wanted to make sure that anyone who, there are those in any race or ethnicity who discounts racism. But for anyone who discounts historic racism being a factor currently, consider this. I have a friend that's a doctor, Dr. Rabb. He's in his 80s. His father was born into it, begins with S and ends with Y. He has, slavery, in other words. He has a son that is in his 30s. Now consider this, if he has a father that was born into slavery, who birthed him, or should I say, sired him when he was, the father was in his 80s, and then he sired his son almost 60 years old, but there are people on the other side that's just like that, and it's just like the man told me he didn't even know his family was racist until a black woman, elderly black woman was walking towards him when he was a young teen, and his grandfather snatched him back up on the sidewalk when he stepped out of the way for the lady. And this was a man in his 40s who was telling me this. Okay, going on, I have one other point to bring up because I know others wish to speak. Going on from that point, I just wanted to make sure that people understand that there are persons that will do odd things, because when we were gathered in one of my sister's rooms, a nurse walked in smiling because we were talking about taking her home, and she immediately dropped, she turned up the drip very quick, and my sister, she died on the spot. The nurse came in like a death nurse and did the drip, but we got to always understand that there's a purpose for all of us. There are different trees and flowers and ants and elephants. It's different everything, and that's a part of the plan and pattern and purpose of God. So under those circumstances, we have to appreciate everyone. Otherwise, we'd be all sitting here, is that Mary or is that, am I married? Is that Bob? Did somebody say they're getting married? We wouldn't know who anybody else was. It would be like looking at a painted wall or a blank sky, day or night. No stars or no clouds. So just understand that. And I am going to try to find you guys so that maybe we can find a way of putting together a grant writing team so you can have more funds to do what you need to do for investigations. But along with that, we need to cover those 30 jobs. It's insane because with salaries running between close to 100,000 and up and up for the jobs, when it's nonsense that people cannot find people to work the job. So let's get the job done. Again, like I said, Cousin Pinky would say, get your work did. So God bless everybody. Get your work done. Love you.
Thank you. Additional public commenters in the room?
Hello, I'm Xavier. I'm a local advocate with Consumer Watchdog. It is really a pleasure to just sit here with you guys and see you guys in person. I hear you guys over the phone a lot and through the video, so to be here in person, it really resonates with me as someone who lost their family and as someone who's fighting for it. And it's humbling to know that my family and these families behind me aren't the only ones, because this is something that we're still working on to prevent this from happening. But like I said before, I'm really passionate about this issue, and I believe that we have an issue when it comes to filing complaints for a baby, and I know that because I experienced it. When I tried to file my complaint, I got the complete runaround from the Kern County Health Department. So I'm asking you to find a way to work with them to help forward deficiencies for the complaints that are being processed. I also encourage that you take action on the topic of 805 reports, and so that when they are filed, they are sent to the medical board. And I just thank you guys again for making it all the way down here, and I really appreciate you guys. Thank you.
Thank you. Additional comment in the room?
I always feel like I'm gonna eat it. Okay, hold on. Sorry. Okay. I'm Monique Himes. I'm from Bakersfield and a volunteer with Consumer Watchdog. I will never forget the day that I watched Malachi fight for his life. But none of his health care providers were fighting along with him. Whew. Sorry. Malachi's care was completely mismanaged. A team from Valley Children's Hospital was standing there in the NICU waiting to airlift him, but the hospital waited 13 hours to airlift my grandson Malachi to another hospital where they had the resources to save his life. Like many other families in this room, this did not have to happen. We can be the change here today. We have the board here, the state department. Let's leave this room with a plan. Mothers are counting on us. Thank you.
Thank you. Additional comment in the room?
And I will bring Danny because we're here because of her story and all the other mothers, and I just feel like she should be here. So when you guys drive through Bakersfield or hear it again, you'll remember that you made a change for the better. But it never gets any easier. But yeah, I am from Bakersfield, and I'm a volunteer with Consumer Watchdog and the founder of Save a Mom and Save a Family Foundation. After my daughter and my grandson passed away, I was devastated. I had to literally pull myself off the floor. I chose to go out and figure how I could make a difference so that no one mother would be struggling to survive and breathe like me, because I couldn't understand. I reached out to Michelle, a Consumer Watchdog, and found that not only a team, but a group of mothers and grandmothers who were facing tragedies like mine. I found my voice for advocacy. I have not turned back. I not only filed a complaint with the medical board, but I also filed the complaint with the Kern County Health Department. They worked with me on Demi's complaint, but they gave me a very hard time when it came to Malachi's. First, they told me that there would be an investigation regarding my grandson's care. Later, they said they would and they wouldn't. There's a complaint on the database, but no one will give me the statement of deficiencies linked to that care. My daughter had no rights. She had a doctor who had been harming mothers and babies for 32 years and allowed to do so. He lost his privileges at 2 hospitals before my daughter and grandson died. There was an immediately jeopardy situation at the hospital that my daughter walked into. She was admitted due to medical errors from another doctor. The anesthesiologist put the wrong medicine in her epidural and she died. We need this health department to forward the 805 reports to the medical board. We need the medical board and the health department to start sharing information with each other to save mothers and babies. I represent a lot of the Latina mothers here who have lost their daughter to this crisis and their babies. We need change. But I also, went to these programs are very good, and I started researching myself, and I was realizing there was none for Latinas. There was no resources available. I couldn't even get into it, maybe attend their meetings, but there was no resources. So that's when I started looking around in my community, and I hardly found any help at all. That's when we started Saving a Mom and Save a Family Foundation. I said, I'll do it on my own. I'll figure something out. She didn't die for nothing. And they'll remember her and Malachi. So we started the foundation, and we put on our very first health fair, Latina Maternal Health Fair. Leticia Perez, supervisor, she made the month of May Latina Maternal Health Fair Awareness Month. And we started at a small church. We had a pretty good turnout. It was 115, but it was our first one. So the second one this year, God blessed us because we had a really good turnout. We had it at Cal State. The college Demi was going to graduate. I walked the stage for her a month after her passing. And we had a good turnout. We had the BC nurses attending. They were interested. I actually went over there and spoke to the nurses so that I could educate them and they could see what a family goes through. Because I think by seeing, they're learning. So they want to be involved next year. They want to have it on BC campus. And then I'm still going to do the Cal State one because that nursing program was also involved. And we had a pretty good turnout, and I was looking for resources and vendors just to bring out to educate mothers. But I also want to go to the high schools. I want to educate the young girls. My granddaughter, she's scared to death to have a baby. So, my daughter, Taylor, had a baby 9 months ago. She literally left Bakersfield to have a baby because it's that bad here. She literally got better care. Doctors listened to her, and they were prepared. For Demi, they were not prepared. They ignored her. They didn't care. They didn't value any of her symptoms, listen to her symptoms. She explained everything and just didn't care. So this is what's happening in our community. And I will continue. And like I said, we did our first Save a Mom Foundation on our own money, out of our own pocket, both years. I don't have any other resources. I don't go looking for it. We do have our foundation, but we're barely starting. But I know it's going to grow because this community needs it. And I am one that will go into the poorest areas. I'm not afraid. Education is going to bring awareness to these young girls that are out there who don't know what to ask when they go in that doctor's office. Why aren't their doctors educating them about preeclampsia? This could happen. You need to look out for it. Why wait till they have it and then it's too late? They're not educating. I would love to put Demi's story on a CD and just play it. These are these symptoms. If you have them, tell your doctor or get a doctor if he's ignoring you. More and more comments and calls that we get daily on Bakersfield moms. These mothers are crying out for help. What do we do? What doctor's good? Where do I go? Who do I turn to? Because we don't have the resources. Plain and simple. The POP that came and spoke, yes, it's a good resource, but it's only up to 36 weeks. So after 36 weeks, you deliver. Things happen a lot after 36 weeks. So I'm just, that's my story, and
I think Demi and Malachi have hopefully can make a change in your life, in your heart, and your thoughts, and your decisions, just to make it safer, because we are hurting in the Central Valley. And I'm very grateful that you came to Bakersfield. Who would have thought you would be here? I don't think you guys thought, years ago, but I thank you guys for listening to all of us and our stories. And like my daughter-in-law, 20 years before, Who would have thought that Demi would be gone? Thank you, though.
Tracy, thank you.
Thank you.
Additional commenters?
Good afternoon. I'm Michelle Montserrat Ramos, and I'm from Consumer Watchdog. My comments were mostly geared toward the Kern County Health Department, and I'm incredibly disappointed that they couldn't stay to listen to what these families had to say, as these families have sat in these meetings for 2 days, as well as I. And as I told Brynn, we had specific recommendations, and as I told Brynn, we'll just take it to Kern County Board of Supervisors to work it out. But I do want to thank all of you. I want to thank all of you for bringing this meeting to the Central Valley and to Bakersfield. As I mentioned yesterday, I was hopeful that these 2 days would be very impactful for all of us, and I really believe that it has. And like I mentioned before, all the families here, those that are left sitting behind me, they've really done the grassroots work. We really pounded the pavement here in Kern County and the Central Valley to try to find resources and provide educational opportunities. And as Tracy mentioned, there's a constant stream of mothers that need help. They're experiencing complications, and their providers aren't listening to them. They don't know what to do. And just in this past week and a half, I literally had to do one-on-one advocacy with 2 families here, local families. One young mother was experiencing pregnancy-related heart failure, and her OB wasn't helping her. And another family where the young mother was in labor for 4 days and claimed they couldn't do a C-section, and they didn't know what to do. This is some of the one-on-one advocacy that I'm doing. And so I hope that you did feel the impact of the past 2 days, of all the families that came forward. And as I mentioned before, and some of the things that we've asked for, starting with a report and leading, as a guide, moving forward with, some type of policy or legislation. I'm really hopeful that we work together, that we can make a difference, start to curb this crisis. Thank you.
Thank you, Michelle, and thank you for everything you're doing in this community and beyond. Are there other public commenters in the room? Do we have anyone on the line? Okay, it doesn't look like we have anyone on the line. I'm going to... No, I'm sorry. You already spoke. So, yeah, it's one comment at a time. Yeah, we're going to move on to our next agenda item, which is agenda item 13. It's future agenda item. It is always a favorite of this group. So, do any members have requests for future agenda items? I've noted a couple myself, but Mr. Watkins, we'll start with you. We can go around the group.
I think in the spirit of what happened here today, I think momentum is a good thing to start moving towards change. I don't want to scare everybody by coming in with the heavy-duty plans, but I thought a good way to proceed would be to suggest a future item that we discuss. We have failed these folks here in Bakersfield, and there's reasons why it has happened. And those reasons I would like to have a discussion about. Those legal reasons of that ties our hands most of the time when we're sitting in meetings, and to really get to have that understanding in an exploratory way, not in an explosive way. So I would like to suggest that we have such a discussion that, that this doesn't just die here in Bakersfield and we all feel a certain way, but that we actually take future actions. We come up with a discussion, come up with more ideas about what needs to change, because from where all of us are sitting, it looks like, we failed everybody, but there's a system that sits behind us that we don't always have domain over, the legislature and others. And I think those conversations we need to start having in an open forum so that we can remedy some of the pain. The only reason, today what was great was there was faces to the many, many nameless people that we see in these white documents all the time. All of us can attest to that. And that was probably the most thing that hit me the hardest. And my second deal was just to, suggest that we perhaps create that another day where people have public comment, And the second day, like we have the first day, I don't even know what this thing is called anymore. Public comments, just public comment. Because I think what I'm missing is, from the documents that we read, is the people's story, their impact. I don't think it has ever come across this powerfully. So that's just my suggestions, but.
Thank you, Mr. Watkins. Other future agenda item suggestions, Dr. Balot?
Yes, thank you, Madam President. I would be interested in learning. We learned that the Department of Public Health for the state of California has data, and I know that will probably come up from what we heard, what we'd like to see reported. But also, I'm interested in the Department of Managed Care, particularly those that are responsible for Medi-Cal, and understanding the by region. Let's take Kern, Fresno, some of these areas in California that have high infant mortality and maternal deaths, and understanding the physician population that is serving those individuals. So if it's a rate per 100,000, some number, I think that's important to know, and we can do a comparative and a review of other areas that simply don't have those same statistics.
Other suggestions or requests? Okay, just a couple from me. One, I would like us to follow up on the survey request that we heard from a number of the advocates today. I know that our data is, these are my words, imperfect, in that we don't always have the right, I don't know what the right word, prompts. It's not always classified the way we would like it to be. So to the extent we can look into it and, one, see what we can do, and then, figure out if there are any steps we need to take to make sure we're collecting data in the right way. I'd love to see that come back at our next meeting to the extent we can put that together. The other thing, I think some of the speakers touched on it sort of briefly or tangentially, but I'd like to understand better how we are collaborating across state agencies and then frankly across some of these county agencies, because and frankly, there were a couple disciplinary cases that we've dealt with of late on our panels where it was clear either hospitals or systems, and it's come up very publicly in the academic context, they had information about physicians that was not being shared. Sometimes it's not being shared because someone's trying to hide it from us. Obviously, that's a problem. Sometimes it's not being shared timely in real time when we could step in and use the powers within our jurisdiction to intervene to make sure bad doctors aren't practicing. And sometimes there's just a complete breakdown or failure of communication for one reason or another. You file a complaint somewhere. I know that sometimes people file complaints with the medical board, for example, that are properly routed to the Board of Registered Nursing, for example. And I'd like to understand what we do when that happens, and then, how we're interacting with other agencies or what other processes exist at other agencies to make sure we get complaints when consumers are attempting to file them and simply file them with the wrong agency because they're not knowledgeable, and frankly, we shouldn't expect them to be about the complaint filing processes. So to the extent we can have that type of conversation, I think it would be, that would be really helpful for me. Are there any other comments here? We usually open it up. Yeah, Dr. Hawkins?
So I'm still thinking about it, and probably the closest thing I've heard, maybe what Mr. Watkins says, is there's a need to sort of debrief and think about all the things, a lot of the things that I heard today, and ask ourselves, within our mission, what can we do to do a better job in our next steps? But we have a certain mission, we have certain limitations. But let's look at what we heard and saw. There's a lot of feeling going on here today, as I mentioned to some of the folks who spoke. But let's figure out what we can do, what our next steps are within our purview, not to diminish anything that's like Ms. Lawson just said about investigating other things. But I mean, I think that we just have to do a debrief and figure out what the next steps are.
Yeah, and before we open it up for public comments to see if there are any, I mean, you know, this type of, I guess, educational forum where we have an opportunity to dig really deep, I think in some sense the pandemic, put a pause on some of the good work we were doing pre-pandemic on a variety of different issues, whether that be physician burnout, the opioid crisis, or things, like we heard about today, maternal infant health. And so I think that the more that we can do these types of things in our meetings, the more we can invite experts and advocates and leaders, I think it's going to continue to be impactful. And it gets us back to some of the types of things we were doing and that perhaps got lost just in the pandemic virtual, and focus on other things. So are there any future agenda item requests from people in the room? Commenters? Please.
Here comes Grandma again. Okay. I'm thinking about the process that goes through that is so lengthy, with the Department of Justice taking 6 months, then your preliminary board taking 3 months, and that if you are holding a body out in order to have DNA done on it, but then you end up holding it out eternally, it looks like. And so I'm wondering if we could work it up to where the DOJ does their review work with and coincide with the medical board preliminary review. And in that way, that will cut down some of the timing, and you'll have professional persons that are in the health field that will be looking to see if there's something strange. Like I mentioned in the case of my husband, his body looks like that it was like in a desert, but in a swamp when you look at his organs. How can you have organs that's reduced that much and other ones that grow up that big in one body, But it's, and then different things came out as far as what the autopsy said. So that's something that should be tested by somebody who is in authority to say something. And you do have the control of who, I forget how it's put, but like everybody knows who's been with the body. It's nothing strange that's come in. And then even while it's in the field, we should be able to get reports, because so many people came in here who are saying that it's been 5 years and more and they never got any answers, and it's like, zzz, that makes you go like, what? Like it's just strange, And I'm asking that you guys consider the idea of doing, as I mentioned before, DNA testing on any remains that are existing, especially when the autopsies conflict. I think I already had said that. But just keeping in mind that if a family is spending thousands upon thousands of dollars keeping a body out, but then, like, the thing that we have run into now is that the mortuary doesn't want to keep the body because it's been over a year. and we still don't have any answers about what is going to take place. So again, I say we forgive those who despitefully use us, but we want to do things so that we can stop them from despitefully using somebody else, so that's it. I saw the yellow light come on. I'm learning the system. So y'all be blessed, just be blessed and prosper in all ways of the Father, and may God's hedges of protection be around all of us as we continue. I love everybody.
Thank you. Let's go to the line. Do we have any requests for future agenda items? All right, we will bring it back to the board unless there's anybody else in the room. Seeing no one, did someone want to jump up on a future agenda item? All right. We will bring it back to the board. I'm sorry, we now have one on the line?
There is one that jumped on.
Okay, go for it. Go for it.
Monty, your line is open.
Great. Thank you very much. What a moving day today was. I watched the entire thing. Heartbreaking in so many ways. And I'm almost embarrassed, but I'm not, because there's another huge population in California that's hurting. And I don't want the board to forget their commitment to maximize the benefits that could be derived from the publishing of the new opioid prescribing guidelines by implementing an aggressive rollout with all of the affected parties. I listened to both days of this meeting, hoping to hear more along those lines. And other the brief mention of it by Mr. Varghese in his report yesterday, I haven't heard it. So I'm imploring the board to not forget that commitment. It's key to the opioid prescribing guidelines that were just published to achieve maximum benefit for the many in California who are suffering undertreated pain for that rollout to occur. So I'd very much like to see the board have that on their agenda. Thank you.
Thank you for your public comment. Did anyone else queue up? Okay, we will bring it back to the board. Our next agenda item is adjournment. A couple just reminders before we do that. I do want to remind the public that if you believe a loved one or yourself was not provided appropriate care under any circumstances, including during pregnancy, labor, delivery, postpartum care, or like I said, any other circumstances, please do file a complaint online with the board so the board may review the matter and may determine whether that physician violated the Medical Practice Act. Our next quarterly panel and board meetings are November 30th through December 2nd of this year. Those meetings will be held in person and will take place in Sacramento at the Department of Consumer Affairs. And then I wanted to again congratulate Dr. Hawkins, who is the board's new president, Lori Lubiano, who is the board's new vice president, and Ryan Brooks, who is the board's new secretary. We look forward to your future leadership. And with that, there being no further business, this meeting is adjourned. Thank you all.